This we wanted to keep it in the live stream and Zoom because so that people, it will be available for the people to know whenever they want. We go to Zoom. Rakesh, co-host. Rakesh, you can share and start. Even Vivek, will you make some few introduction or anything?
Yes, sir, sure.
Please.
So good evening all, and welcome to this session of IRCF, where we are going to discuss, and we are starting our session with the topic of Dr. Rakesh Garg, who is well known and doesn't require any introduction. He is a professor in anesthesia at All India Institute of Medical Science, and is the core member of the IRCF, who was instrumental for the guidelines in 2017, and throughout he is working for upliftment and improvement in the guidelines and working on the recent updates on the guidelines. So he'll be talking with us to us what is new and what is new in the CPR guidelines and what is different in IRCF. So over to you, Dr. Rakesh.
Thank you so much, sir. Thank you for the kind words, and thank you everybody for joining today's session. So we have the IRCF guidelines way back, and there were certain changes which were different from the international guidelines or international science, which were as part of the Resuscitation Council. So it was important to understand that when we frame a guideline for a particular geographic area, it has to be specific to the population that it caters. The science always follows the applicability of a particular science on the patients that we are looking for. And that's the reason there has to be certain differences based on demographic profile, based on geographical requirements, and based on various other parameters for an individual area where any science needs to be implemented. And same would be applicable for the resuscitation science also. Same will be applicable for the resuscitation science also. We know that in India, when we talk about the cardiopulmonary resuscitation need, the mortality due to sudden cardiac arrest is huge. And we also realize that majority of them, this cardiac arrest would happen at home or maybe outside the hospital premises. And majority of them will have an increased mortality because immediate care may not be feasible because of various reasons. And the most common reason is the requirement of immediate CPR, which has to be done preferably within minutes, maybe within seconds also. So earlier we do, better it will be, because we know that the chances of successful return of spontaneous circulation decreases almost by 7 to 10% with each minute. So we have to work as fast as possible, as early as possible, so that the outcomes improve. Now, when we talk about the CPR guidelines across the globe, we understand that there are only a few resuscitation councils who has made these guidelines. And the evidence or the science from many of the places is not available. So in the absence of the available science or in the absence of available guidelines for that particular area, the guidelines from other council has been adapted in the past to other areas, as we also have been doing in India, because a decade back, we were not having our own dedicated guidelines for our country, and hence we'll be using it. Though the science is not wrong for using it, but its applicability becomes an issue. We also need to understand that there are many regional variation of parameters, with resuscitation outcome improving them if the teaching and the persons coming out with resuscitative efforts increases. But then with low public awareness about the sudden cardiac arrest, about the resuscitation steps, this is not very high in countries like us, and we have to work on this. It has been very well seen that those communities where the teaching and training, the sensitization and awareness about the resuscitation is high, the outcome of patients with cardiac arrest victims are high. So we need to have a timely and optimal CPR for each the patient with cardiac arrest. And for this, we have to have the robust guidelines, which is probably maybe universal, but adapted to the national requirement. The international guidelines does not fit in all Indian scenario because of various limitations. And that's the reason that the Indian Resuscitation Council Federation developed their own guidelines. And for the first time, in fact, the compression on life support guidelines, a dedicated guideline for layperson was developed, which is for the first time in the resuscitation science where dedicated guidelines was made and released. We also followed the links which were based on the science available for three basic aspects: the layperson, the medics, paramedics outside the hospital primarily, and the comprehensive guidelines inside the hospital, which was then followed with stepwise approach. And this is well supported by various other professional societies and bodies, not only in India now, and being an ILCOR member, it is supported by outside India. Now, what we need to understand is when we talk about the science is emerging. We also see into our clinical practice that many of the things which we were doing, say, 1 decade, 2 decades back, they were not wrong 2 decades back. They were doing it rightly, but with the change in the science, with the understanding in the science, with the advancement in the science, probably those things are not correct in today's parlance. And hence we need to change ourselves, we need to practice those updated things, and same would be applicable for the resuscitation also. And resuscitation also, everything started somewhere in 1950s or so, and it is almost now 70, 75 years where we have now a lot of science behind the resuscitation which has come up, and we have put so many things into the system. But still, because of many ethical dilemmas and conduct of good randomized controlled trial, when we talk about the science, the scientific evidence is not robust for many of the aspects. And that's why sometimes we have to put an expert opinion. Sometimes we have to extrapolate them. We have to extrapolate them for suitability of the population that we are catering. And this is how we have emerged for. If you see the Indian Resuscitation Council Federation guidelines, there are subtle changes. And those subtle changes has been incorporated with some evidence behind it, which is suitable to our population. So I will touch few of the aspects so that you can understand them more clearly, that why these changes are and why they are more suitable for our population. Now, what we need to understand is when we talk about resuscitation, basically there are three basic aspects of it. So whatever the algorithm stepwise approach we follow, when a patient gets into any cardiac...
This is all India level, this one is going on. So
when we get into any cardiac event, there will be three basic phases that the patient will go in. This is the first is the electrical phase, and then the circulatory phase and the metabolic phase. Now, the first few minutes of the cardiac arrest is basically the electrical phase, wherein the patient heart will have some electrical activity, but they have disorganized activity. At this point of time, probably perfusion will be happening. The patient may not suffer from ischemia, but these are the patients which requires electrical therapy. And that's why if you see the resuscitation guidelines, the emphasis is on earlier defibrillation, because this is the electrical phase where we have to now revert the rhythm back to a normal sinus rhythm so that the ischemia is not happening to the cardiac muscles. Now, if this early phase is not tackled, if the patient does not receive the initial resuscitative efforts, including the defibrillation or the AED. Then comes the circulatory phase. Because these type of disorganized cardiac activities or arrhythmias will not persist in the same fashion for long. It's usually ventricular fibrillation in the beginning. But then in the circulatory phase, which usually starts a few minutes later, maybe 5 to 6 minutes, and this is where the patients will start having ischemic injuries to the cardiac muscles. And that's what we say, if you see these two periods of up to say 6 to 7 minutes, we have to act here. Because once the insult to the myocardium starts happening, it becomes difficult to resuscitate these patients because the reserves will be less. The functional myocardium will start decreasing thereafter. And hence, the early defibrillation or early CPR is paramount because of these two reasons. Now, even sometimes if the heart muscles are good and if you start CPR a little later, there would have definitely some ischemia happening to various organs. It may be the myocardium, it may be the brain cells also. And here comes the role of post-cardiac arrest care because some injury has happened. So that's why we have to prevent further injury to happen and probably whatever the injury has happened to recover it back. So these are the three phases. If you remember, or if you see any of these algorithmic approach, they follow these steps. Why do we say early CPR? Why do we say early defibrillation? This is the reason. Why do we say post-hypothermic care or post-resuscitation care in the form of hypothermia, which was mentioned earlier? This is the reason. So we need to understand this basic physiology for cardiac arrest and how this is impacted. Now, second thing is, though we usually use the term cardiopulmonary resuscitation, but if you see even the calls, the layperson guidelines, there is some de-emphasis on the breathing aspects. So actually, we are not resuscitating the pulmonary aspects directly more aggressively, but what we are also resuscitating is the brain. So we have to put it somewhere because if you delay it for some duration, the patient will have hypoxic brain damage and the patient will be brain death subsequently, even if there is a turn of spontaneous circulation. And hence the concept of cardiocerebral resuscitation is very important because this emphasizes the high quality, minimally interrupted chest compressions, and this is what the emphasis is. So sometimes when we have a question that why we are not putting up breathing for the layperson resuscitation, probably this is the reason. And that's why the circulation airway breathing, as opposed to the classic airway breathing circulation of the earlier decades, was changed. So that's why when we say the breathing aspect is not much emphasized, if we are able to do it well as a medics, if we are not able to do it, but do the high quality chest compression. And when we talk about the layperson, I have heard many times that people want to give mouth to mouth outside the hospital by a layperson. I agree, if somebody expert is there, you can go ahead and do it. But breathing, those who are anesthesiologists listening to us, understand during their postgraduate training that teaching somebody breathing requires some time. It requires some experience. It requires some practice. How can we teach it to a layperson? And for these two reasons, one, the concept of cardiocerebral resuscitation and the concept of difficulty in training in breathing to the layperson made us to put up the guideline as compression only life support. And this is well accepted into the science and across the globe also. So this is what I suggest strongly, that when you are teaching the laypersons who are not into the medical field, breathing is not required to be taught to them because of this reason. Moreover, when you are teaching them a good quality chest compression, if you remember, some of you, if you are aware of the history of the ventilation, there used to be something called the iron lungs, where again the chest was used for the purpose of chest expansion, was used for the purpose of breathing. So if you are compressing the chest at the speed of 120 compressions per minute to a depth of around 5 to 6 centimeters, it will also lead to some amount of ventilatory exchange. And that's why.
Are the slides changing?
It is because of this reason that the layperson CPR, we are more emphasizing on the good quality chest compression. And that's why the terminology of compression only life support for layperson is very well acceptable. And we should not be teaching breathing for these patients. Yes, in areas where there availability of AED, probably that needs to be integrated into the layperson CPR. And India, as and when in those states the AED will be available, the IRCF will be integrating the AED into the guidelines for layperson CPR. I fully agree that early defibrillation is important. It should be given for all patients, but only because of the infrastructure with regards to AED availability at most of the places, it has not been incorporated. However, it needs to be clarified very clearly that places where they are available, they need to be integrated, because we need to teach layperson clear-cut strategy what to do when they see a cardiac arrest victim, and they should not be missing something that this is not available, that's why they're not doing it. So you should be teaching them compression only life support as of now. No breathing needs to be integrated for layperson while teaching layperson CPR. And whenever AED is available in states by the state governments, yes, we will, IRCF will integrate the AED into the system also. Now take me through very basic things of the chest compressions and ventilation aspects. Now there have been certain variability with regards to the site of chest compression, the speed of chest compression, the compression ventilation ratios, which has been put by various resuscitation councils. And IRCF is little different from them. Not much, but little bit. I'll explain you that why this difference was required for IRCF to integrate. Now, if you see the various signs and resuscitation guidelines for optimal hand position for chest compression, the various guidelines has put various sites where the chest compression needs to be done. It may be 2 fingers above the defeat process, which is primarily by the Indian Resuscitation Council Federation. Some resuscitation guidelines mention as intermemory line or internipple line, and other guidelines even mention as lower half of the sternum. Now, basically what we need to understand is that when we are compressing the chest from outside, it should be compressing the heart from where the cardiac output can take place. Whatever the blood is there into the ventricles, left ventricles, they should be going out of the heart. And hence we need to identify that area. Now, this area, which is by the Indian Resuscitation Council Federation, has been found to be most appropriate for the Indian population. And the reasons are many. The reason primarily is, if you see this interesting paper, which is way back, almost around 15 years back, where they talk about the internipple line. Is it the correct hand position for effective chest compression in adult cardiopulmonary resuscitation? And they have done a very nice reconstructive images from the CT scans. And they have tried to identify, based on the external structure of the intermemory line, and by this 3D reconstruction of the CT images, they have tried to identify which structures underlie the intermemory line or internipple line. So when they have tried to analyze these structures, right? If you see this section here, this is the TF sternum. They have tried to identify the structures. They have tried to identify the intermemory line here. And then in this 3D reconstruction, they have tried to identify that which are the structures which lies behind the intermemory line through these reconstructive images. And when they have tried to identify these structures, they have included various demographic profile of these patients also. And they have tried to identify based on this various distances measurement. And the conclusion was that in this study, almost of 189 patients, in almost 80% of patients, that's a huge number, 80% of patients, the intrathoracic structure that underneath the internipple line was the ascending aorta, the root of aorta or the left ventricular outflow tract rather than the left ventricle. So left ventricle was just in approximately 20% of patients. So this means in this situation, almost 3/4 of the patient, we were compressing a structure or structures which actually need not to be compressed, which was not in tune with something called good quality chest compression. Because we were not compressing on the left ventricle, which leads to the outflow. We were compressing on the structures which will impede probably the outflow or will not lead to the outflow. So this is an important parameter. And this is more of an population or a demography which is more comparable to our Indian population. And based on this, they try to identify that which area on the sternum would be most appropriate. So they have tried to identify the structures. And they have said that the coronal CT image plane of maximal heart diameter was around 2.8 and 2.3 centimeter kiphoid to gyphoid process in males and females respectively. So this 2.8 and 2.3 centimeters was calculated from the gyphy sternum or the gyphoid process. And also they also mentioned that the internipple line was 6.2 and 5.6 centimeter kiphoid to the gyphoid for males and females. So if you understand or extrapolate these measurements and the structures, it becomes very clear that the interlepen line probably is not the correct site for putting the chest compression site on Indian population. And also from this image, it appears that somewhere around 2.5 centimeter, it will be about 2.5 centimeter from the gyphy sternum, which would be approximately, say, around 2 finger lengths. We have another study which was also published around 5-6 years later, in which they again have used the CT images to identify the various structures. And in this again, they have re-emphasized that only a small proportion of ventricle is subjected to external chest compression when CPR is performed based on the internipple line or intermemory line. And the compression of sternum at sternogiphoid junction might be more effective to compress the ventricles. So this means we have to go down somewhere below the internipple line or the lower half of the gyphy sternum, which was again recommended by certain resuscitation council for the appropriate site. And again, in this, they have tried to measure the distances based on the CT images at which structures lies and where are a site on the gyphy sternum which would be more appropriate to compress upon these. And they have tried to now illustrate the areas. They have tried to divide into internipple line, halfway between internipple line and sternogiphoid junction and the sternogiphoid junction. And they were able to identify that the most appropriate site where the widest total ventricular area was seen in patients was between somewhere halfway between A and B. And this is what we need to remember very clearly, that the site we need to identify is more appropriate somewhere between the internipple line and the sternogiphoid junction. So this is again corroborating with the previous study which I have shown you, that the patients where we use the internipple line probably is not the correct site. If you go to the sternogiphoid junction, probably it may not be the right structure. So we have come somewhere between the internipple line and the sternogiphoid junctions based on these studies. Now, again, this is another interesting studies where they have tried to use the site of lower half of the victim sternum at the center of chest between the nipples. So they have used the term which is a little vague here, and they have found that the outflow of left ventricle is affected during standard CPR, resulting in varying degrees of narrowing in the left ventricular outflow tract or the aortic root. So means these are the various good imaging studies in which the population was, demography of population was almost similar to the Indian population, and hence this becomes an issue that which should be the right site. There was another study in which they have used the transesophageal echocardiography, and again they found that during CPR, the outflow of left ventricular is compressed during standard CPR when intermemory line is used. So not only the CT image is based, but also during the resuscitative efforts, when they have used the transesophageal echocardiography, they have found that probably the compression was on the left ventricular outflow tract or the aortic root rather than the left ventricle. Similarly, if we see the clinical translational value, this was another study in which they have looked for the hemodynamic effect. Earlier, we were talking about the CT images. So those were more of an anatomical things that we're talking about. But if we talk about the hemodynamic effects, here again, they found that the internipple line was giving less hemodynamic changes as compared to the other sites. So in this study, compressing the lower end of the sternum appears to be an alternate method which generated higher arterial pressures and higher end-tidal carbon dioxide pressures that we want than standard CPR procedures where intermemory line was being used. So this means not only the anatomical portions, but also the physiological studies or the hemodynamic studies were also hinting that the site has to be appropriately chosen. Now, this is another important study when we say go down the lower diffuse sternum. This was another last study from Singapore, where they were using the lower half of the sternum, and they were saying that compress more caudally than the intermemory line. They found that almost 40% compressions were on the epigastrium. So this means when lower half of a sternum is empirically mentioned, we can go a little lower and it will be more in the epigastrium. Again, not only that we are not compressing the heart structures, but also we can damage the interabdominal structures. And hence, there have been many studies subsequently, which again has assessed those aspects. Now, this was an interesting radiological assessment because when we talk of a sternum, a bony structure, it's a bony structure and it's usually fused. The cartilages are usually fused in these structures. And when we try to press these structures over the sternum to the heart, this anatomical variation in the shape of the chest of sternum could vary among the various demographic profile. Now here, based on this, if you try to compress it, though we expect that this is a single structure, wherever we go up and down, it should have pressed the whole sternum. But actually, this does not happen. Usually, a 4 to 5 centimeter posterior displacement of sternum at its superior end would cause compression of structures passing through the thoracic inlet in trachea and nasal arteries. So this means if we are a little higher, again, it will be compressing various other vascular structures and hence emphasizing the right time. And this is the reason that the IRCF had chosen this landmark of identifying the lower end of the GF sternum and then going up 2 fingers above so that we are balancing both aspects. We are neither too up and not too low, and we are able to identify one of the best structures. But at this juncture, I will also request many of you, if you can undertake this study in the form of CT reconstructions or using transesophageal echocardiography, you can easily look for that in Indian populations from north to south, east to west, which should be the most appropriate structure. And this will be an interesting study to look for. I think a simple study may be done in non-cardiac arrest victims. So please plan this accordingly and try to publish it. It will be a huge data. So this is what IRCF has done based on this. Now coming to the second IRCF difference, which is regarding the guidelines with regards to the speed of chest compression. Now, if starting from the way back, it was 80, then it came to 80 to 100, then at least 100, then it came to 100 to 120. And IRCF mentioned is to be 120 compressions per minute. Though we do agree that there is no robust recommendation for any of the resuscitation guidelines. Even by AHAs or ERCs, they are not robust guidelines, which is the most appropriate one. And we need a large studies again. I will again request all the listeners to plan a good study to look for which should be the one. But looking for this landmark studies based on which majority of resuscitation science has emerged as to be which is the most appropriate one, in which they have looked for the influence of compression rate on the initial success of resuscitation and 24-hour survival in animals who has received the circulation and received the resuscitation. And here they have found that, there they found that when the speed was almost at the speed of 120 compressions per minute, in those situations, the outcome were really good. And then subsequently also we understand that when you start compressing the chest, we have to balance two aspects. One, it should be at good compression speeds, maintaining the coronary perfusion. But simultaneously, we also have to allow time to require to refill. So another studies which has come up, we have mentioned that probably it appears that the balance between two would be the somewhere around 125, 126 compressions per minute. Because if we go too high, then the required time is too less and the filling may not happen appropriately. So based on this, it appears that the rate of 120 minutes, which resulted in a higher systolic, diastolic, and coronary perfusion pressure is appropriate. And in another good retrospective analysis of almost 3,000 patients who had an out-of-hospital cardiac arrest, the ROSC was maximum, in which the compression speed was 125 per minute, and then declined even those compressions were not significantly associated with survival. So this means this appears that the speed around 125 appears to be the most appropriate one. But then we also need to remember that the issue of fatigue happens. When somebody has to do a resuscitation efforts specifically to the chest compression, after some time, there will be a human fatigue and it tends to decrease. So even if we put it 100 to 120, and if somebody starts at 100, the fatigue will bring it down. And that's why not only ensuring the good quality chest compression is important, rotation of the chest compression is important, but a maintenance of speed around 120 is the most acceptable one as per the associated available evidence that we have. The third aspect is with regards to the compression and ventilation ratios, which is 30:2. This optimal ratio, we don't have a very robust evidence till date. It was accepted somewhere in 2005. Earlier, it was 15:2 also in previous guidelines before 2005. But it appears that why 30 compression has been kept without stopping in between, because when we start chest compression, it takes around 8 to 10 compressions for improving the coronary perfusion, and then it gets sustained if you are providing good quality chest compression. So we want that at least during the 30 compression, the patient should have sustained coronary perfusion for at least 20 to 25 compressions. If we keep it less than that, it will take around 8 to 10 compressions to pick up the coronary perfusion. And the moment we stop the chest compression, it becomes again back to zero. So if we keep it less, that is the ratio change to something different, probably the coronary perfusion period will be very, very less. And that's the reason that 30:2 has been an accepted norms for majority of resuscitation guidelines across the world. And also we remember when we talk about the layperson CPR, that's why we say that you don't have to check intermittently. Continue so that the coronary perfusion pressure is maintained throughout high quality chest compression, and we are not interrupting, because the moment we interrupt, it comes down to zero. There has been studies where the survival rates for cardiac arrest has remained around 9-20% and VF around 40%. And here what they have done is, that on the 10th compression, the provide handling the breath gives a single 500 cc breath in between compressions without any pause in the compression. So probably I think this may be upcoming, and this has already been incorporated in the guidelines where the patient is on definite airway, that we should not be interrupting the chest compression if the patient is on airway endotracheal tube, because it maintains the coronary perfusion pressure to be continuously. But then again, this studies again hints that probably without interrupting, breathing can be given intermittently in these patients. We have to give more signs, but the crux is that we are keeping 30:2. That's why we are trying to not to minimize, try to minimize the interruption, the chest compression, and 30 speed has to maintain for across all the groups of COLS, BCLS, and CCLS. With regards to the pulse check, this is again important. We understand that the checking of pulse is important. Now, this probably is coming maybe somewhere in the future. We are looking for something new here, that the dedicated experience can check the femoral pulse during chest compression, so that as soon as the pause in chest compression to assess for cardiac rhythm occurs at the end of 30 compressions 5 times, the pulse can be very rapidly assessed along with the cardiac rhythm in less than 5 seconds, because we want to minimize the chest. In future, we need to look for whether this type of technique is really improving and reducing the or minimizing the chest compressions in these patients. But probably this appears to be something good. Though no evidence right now, this is just an hypothesis. People are looking towards it. Probably this may come forward. Also, what people believe is that when the perfusion is very less, the cardiac output is very less, do we really need to check for the pulse? And that's the reason when we are talking about the layperson CPR, we are not teaching them the pulse check, because it becomes too difficult in low perfusion state to check for the pulse in these patients. And hence, we should be a little cautious in spending more time for checking pulse. Because if we are not able to check it within 5 to 10 seconds, even though if it's maybe very, very feeble, we accept it as not and then take it further in the form of chest compression, because chest compression will do more benefit than harm in such situation. Moreover, we are looking for the other parameters, which is the end-tidal carbon dioxide, which again is one of the important parameter for looking for the perfusion happening in these organs, and hence it needs to be used for resuscitative efforts for the good quality of chest compression. A trial in NHM way back, they compares continuous versus uninterrupted chest compressions and find that as long as the chest compression fracture is more than 75%, then there appears to be no difference in survival. So that's why we are trying to focus on checking additional things, spending additional time on other things, so that the chest compression fractions remains more than 75%, and then it improves the outcome of the patients with cardiac arrest. With regards to the epinephrine, again, the effectiveness of epinephrine during CPR remains a little controversial, though it is one of the drugs which has been regularly used across many of the guidelines of many of the decades. The epinephrine has been shown in RCTs to improve the rates of ROSC, raises coronary perfusion, but the association with neurologic outcomes is not related to the use of this. And hence, we need something very robust for confirming it. And that's why if you see various trials, there has never been a choice vasopressor medication that has shown any long-term survival. Short-term survival, yes, it can lead to improvement. However, long-term survival, this is not very important. Hence, again, I come back when we talk about the importance of BCLS and COLS. It's just not the drugs, but it's always a high-quality CPR, which is very, very important, along with the defibrillation, which remains important, rather than coming to the drugs, which again has no unproven role with regards to long-term benefit. And when we talk about the resuscitation efforts, yes, we have to talk about the long-term benefit in these patients. The vasopressin was removed from these guidelines, which was one of the components where vasopressin used to replace one of the dose of epinephrine, because it was not found to be superior for even short-term outcome or long-term outcome. So that's why it has not to be incorporated into the recent guidelines. The other important aspect is with regards to epinephrine timing, the dose and frequency of administration, underlying rhythms and diagnosis. We know that the epinephrine right now is being given every 2 to 5 minutes. It's usually given as 1 milligram diluted. It has to be flushed. and it is used for all cardiac arrest rhythms in general. So the various aspect is not very sure, but then there are literature will say that the earlier administration in first 4 minutes during the circulatory phase, which I mentioned in the beginning itself, may improve the long-term outcomes when patient is starting having from the electrical phase of disorganized rhythms to ischemia onset. This is a time where it will work maximally rather than in the metabolic phase. And hence, that's why whatever the benefit it has should be given at the earliest. And that's why the integration of comprehensive cardiopulmonary life support is important. That's the importance of Code Blue, and that's the importance of team dynamics that has been emphasized time and again. The frequency, this has to be repeated every 3 to 5 minutes. Too high a dose or too frequency given may be detrimental for patients' perfusions. And it has been seen that using this duration, because of its T-half, it is found to be the most optimal one. But once it has been resuscitation, if you are using as infusion, you definitely should titrate it as per the patient response, and which is primarily the hemodynamic parameters and the end-tidal carbon dioxide. With regards to the underlying rhythm, yes, most patients who has cardiac arrest usually have VF as the terminal rhythm. And the lower the dose of epinephrine in patients with VF to minimize the vasoconstriction of coronary arteries is at 1 milligram, and that's why this dose has been recommended for VF. And that's why this has been found to be important. Now, with regards to the non-shockable rhythms like PA assistly, the early administration of epinephrine may be more beneficial than in patients who presenting rhythms with VF. So that's why it has been, though the evidence is not very robust, but it has been used in all the 4 rhythms, cardiac arrest rhythms of cardiac arrest. When we talk about the recent ILCOR science updation, they have very clearly mentioned that ILCOR recommends against the use of combination of vasopressin and corticosteroids in addition to the usual care for adult in-hospital cardiac arrest because the outcome is not affected. And they have also suggested against the use of combination of vasopressin and corticosteroids in outside hospital setting also, even if it is being in ambulances. And that's why both the drugs are not being used for resuscitation now onwards. Now, coming to the important aspect of the hypothermia. We understand that hypothermia appears to be protective in patients who have suffered injuries because it will decrease the metabolism and probably it will try to have the a little protective effect on the injured organ, which has happened during the cardiac arrest. And there have been studies in which they have tried to find out those patients who has suffered cardiac arrest and they have been provided hypothermia to look for how they appears to be. But the point is, when we are talking about the short-term and long-term gills, that there have been various controversies, and looking for the regarding the targeted temperature management, where the temperature has been kept too low at 33 degrees Celsius, they are found to feel the difference in the outcome, especially with regards to the neurological outcome or with regards to the mortality. And that's why keeping a too low temperature in these patients may not be advisable. And that's why people have started putting that keeping a temperature of hypothermia at 33 degrees Celsius is not a good option. And that's why even the resuscitation science has come up that the hypothermia in adults for out of hospital cardiac arrest with initial shockable rhythm at a constant temperature of 30 to 36 degrees Celsius, and they recommend against the active cooling. And that's why if you see the recent guidelines, they are keeping it between 30 to 36 degrees Celsius. And the most recent guidelines has been talking about avoiding the pre-hospital cooling. And if the cooling is being done, it should be in a controlled manner, and it should be somewhere between 30 to 36 degrees Celsius, more towards the higher end. With regards to the airway management in CPR, as I mentioned in the beginning, that the chest compression is the most important aspect. But then simultaneously, when we are talking about the ventilation, because if we can put it, we can start uninterrupted chest compression if there is a definitive airway. Controversy still exists that what should be there. Because what we exactly want is high quality, uninterrupted chest compressions. Now, when we are trying for a trained person, fine, we can go ahead and do any devices because they are trained. They can use bag and mask ventilation. They can go for endotracheal intubations also. But when we talk about lay rescuers, this is not indicated, so it is not being recommended. Even for paramedics, they should be little focusing on airway management strategy, which is much more easier, which provides uninterrupted chest compressions, and that's why we should be little cautious. There is something upcoming, which is upcoming in these patients, that once we keep the airway patent, the continuation high flow oxygen supplementation is important. And this is what is upcoming. Even though if we are not able to manage to have a definitive airway, if there is some issues with the airway management, we should not be interrupting the chest compression too much. We just can keep the airway patent and we can give them a high flow oxygen. And with the emerging evidence which is coming from high flow nasal cannulas and devices, probably which we can go even up to say 50 to 70 liters per minute, probably these appears to be an accepted norm, and this will probably come into the guidelines in subsequent years that this needs to be provided. Earlier it was 15 liters per minute at the highest flow, but now we can go a little higher for these aspects. The mechanical CPR devices, there are many devices which are available, which are being used for this purpose. But remember that they have certain issues. In multiple randomized controlled trials, mechanical CPR has not shown superiority to a good quality manual chest compression, specifically when we are talking about in-hospital cardiac arrest. These devices are good for transport or in the ambulances because the movements will hamper provision of good quality chest compression. But when you're inside the hospital, probably the manual chest compressions appears to be more acceptable. This is one of the most controversial signs. We do not have a definite duration for how long we should continue CPR. It has to be individualized. Remember that what we need to follow is that before we stop CPR, we should try to reverse the causes which are responsible for cardiac arrest in that particular patient. So we have to reverse those reversibles before declaring that this patient cannot be should not be resuscitated further. The next important aspect is regard to the shock dose or how much energy. I mentioned that defibrillation is one of the important, should be done in the earliest phase of electrical phase, that is within few seconds. But then how much is the correct energy that needs to be delivered? What is the optimal energy that needs to be delivered? Now, if you see the type of defibrillators we have, we usually see these defibrillators providing a biphasic truncated exponential waveform, or they have a rectilinear biphasic waveforms. Most of the recent defibrillators have these type of biphasic waveforms as compared to monophasic. Now, in monophasic, usually the higher energy is required. For biphasic, lower energy is required. Now, what or why are we giving this energy? Because the arrhythmias that are happening needs to be reverted back. But we also need to understand that the higher energy is going to damage the electrical conduction system as well as the myocardium, and probably their survival may also decrease. So this means we have to choose somewhere where our optimal energy is required for these patients. If you see many of these guidelines, which has found that they have used the high energy versus lower energies, and they found that the patients in VF benefit from higher biphasic energy levels if multiple defibrillation shocks are required. But we need to interpret this study further, that if a patient is not reverting back to a normal sinus rhythm, then we need to escalate the energy. But giving a high energy at the first point itself probably may damage the myocardium and the electrical conduction system also. And that's why various people has proposed a three-phase time-sensitive model of cardiac arrest, where we need to start slow. And what is mentioned is that start low and go high. Now, this is what we are now. If you see the guidelines which are coming around 5 to 10 years back, we were more trucking towards around 200 joules, and we are fixing at that point of time. Now, what we are moving it, what the science is coming up, that rather than damaging, we have to go slower. Maybe 120 joules is sufficient. But if the patient is not responding, if the electrical conduction system or electrical system or arrhythmias or the focus is not reverting back to a normal sinus rhythm, subsequent energy may be escalated. And this escalation, I'll come a little later, can go much higher. Now, we are not even sticking to 200 joules now. If you see the recent defibrillators, they are going up to 360 joules because the lower energy is not reverting back arrhythmias into a normal sinus rhythm. So start low and go high. And that's why the IRCF has very clearly mentioned about 120 joules. Now, secondly, we also need to understand that these studies which are coming from places where people have higher BMI, they were more obese, the delivery of the energy from chest to heart needs to be understood. There have been very recent equipments which are coming up, which is called individualized delivery of electrical therapy. Now, when you deliver a shock energy from the chest, it has to pass certain structures which will not allow to pass the energy. So there will be certain impedance, and air is a bad conductor of electricity, you know. So if somebody is an obese one, if has a large lung, large chest cavity, in those situations, probably whatever you deliver may not be going to the heart because of those impedance which is impeded by these structures which are poor conductor of electricity. If you see the Indian demography as compared to the Western population, Indian population still is not having a very high BMI as of now. And hence, the impedance will be little lesser as compared to the demographic population of the Western population, which has been reported in studies earlier. Probably this is again an additional reason not to use a high energy in these patients because of low impedance, because of low BMI. I will say not low BMI, but lesser BMI, so that impedance is less. But yes, in future, we are looking for checking for the impedance also, which is being there in certain equipments now, and that will also be taken care of. Simultaneously, this is an interesting study which has been again endorsed by ILCOR also, that if the patient is not responding, if you remember the journey, the initial was the single shock. Then comes the stacked shock. You give one shock, you give second shock immediately, and then came again back to single shock. Now what we have come is, we have come up with something called dual shock therapy for refractory ventricular fibrillations. Now it is what the sequential defibrillation therapy has come up with a good article where you need to use two equipments in patients with refractory VF so that these patients can be given appropriate therapies. Just to summarize, this is already into a guidelines, the reversible causes. Many of you remember 5H and 5Ts, but if you see the Indian population, India is a diabetic country, the chances of trauma is very high. So that's why we have to incorporate certain other reversible causes, and that's why hit the target is important. The relevance of COLS, I already mentioned in the beginning itself. This is just to emphasize that the importance of COLS is important. Chest compression is important. Breathing may not be important for the initial aspect. And as soon as AED is available at various places, IRCF will also incorporate AED into the COLS rhythm itself. And there have been many studies which has found that the CPR by layperson has improved the outcome. So that's why IRCF has been continuously putting a lot of effort in bringing out many training programs for layperson CPR. And that's why we are not emphasizing the ventilation aspect for the layperson, because it has many deleterious implications because of various limitations. Now, are we done with the CPR progress? No, we are emerging. There are a lot of modalities which are coming up. I think many of the things with the involvement of artificial intelligence, everything probably it will come in near futures. People are working on it. So probably we think that this will come into the near future and this will improve upon. What other thing is coming is the use of ultrasonography. There are certain situations when we're talking about reversible causes. Many of the places do have ultrasonography. This may be applicable for in-hospital management. If you have, try to look for those reversible causes by using focus, because when we say we don't have a time frame, but you have to reverse the reversible causes. And there have been studies in which they have found that the cardiac arrest during cardiac tamponade, pulmonary embolism, or MI, if you use the focus, you can identify and try to take care of them. So probably the focus will be integrated again as and when ultrasound and its experience is emerging. It is available. IRCF will also consider incorporate in a selected group of population with expertise where it can be looked for. And the ILCOR has mentioned clearly just last year that the routine of use of focus during CPR to diagnose reversible causes can be suggested in patients where the expertise is available. But remember, it should not interrupt the good quality chest compression. So to summarize, I've tried to put many aspects. When we say the recommendations, the science behind it, possibly there is an ethical dilemma because we cannot do a robust randomized controlled trial for clear-cut indication of doing something or not doing something. But simultaneously, I will also request each one of you that there is a lot of scope. I have mentioned few research questions for you during my talk. I will request each one of you to look for those research questions, collect some data. IRCF is planning to have its own registry, do some studies, observational studies, demographic data from your patient profile, maybe just on volunteers also. And this will help us to look for some robust guidance, which is very well suitable to our population. So thank you so much. And thanks again. Over to Dr. Vivek for further comments.
Thank you, Dr. Rakesh, for a wonderful deliberation and covering every aspect and justifying each and every component of the guidelines of Indian Resuscitation Council Federation. So we are in the process of updating guidelines. And before I open the house for the question, I have just two quick comments and one question from you. Quick comment is one, I think in future we should incorporate the compression fraction ratio also in our important, because it is one of the very important aspect emphasizing the how important is the chest compression. And second, because India is having a healthcare system on both the extremes, with the minimal facilities also and extreme of facilities. So possibly there is some role of ECMO CPR. At least we can incorporate in hospital ECMO CPR, which can be helpful, which will complete probably along with the ultrasonography. We can incorporate the ECMO CPR. So my question from you, that how was your journey from 2017 to 2024, starting from beginning of the guidelines and where we are standing now?
Shiva, please mute yourself. Shiva, please mute yourself. Okay, sir.
I think, thank you, sir. I think I must appreciate and acknowledge the support and contribution from each one of you across India, because you all understand that we do need our guidelines. We do need our robust, structured approach for management. And the journey is quite comfortable because many people across India have supported the various aspects. And they have been contribution from many, many people across India. People have put their experiences, they have commented upon changing into these guidelines, they have suggested certain changes. They have been the expert opinion, because I mentioned that we don't have very robust evidence from India. As of now, we don't have many studies from India. So it becomes very important to understand people's experience. And I'm very happy, IRCF is very happy that the people across India has been very, very supportive for providing their inputs so that we can come up with a guideline which is very well acceptable, not only in India now and across the globe, because Indian guidelines are being scrutinized by various resuscitation councils and ILCOR also. and they have found it that it is very robust and very suitable. And I'm sure that all of you, each one of you, will continue your support to the IRCF so that we can come up with more robust guidelines in the coming time when we are updating them. And please do guide us with your experiences. And simultaneously, I would humbly request each one of you to come up with more research projects. Even just observational studies would be good enough, which can be easily done. And when the IRCF comes with the registry, I will again request that please contribute to it so that we can have the most robust guidelines based on evidence from our own population.
Thank you, Dr. Rakesh. House is open for the questions. You can unmute yourself and ask questions, or you can put the questions in the chat box.
Hello.
Yes, sir.
Yes. Yes, Dr. Anuj.
Hi, sir. First of all, thank you, Professor Rakesh Garg. It's an excellent narration and updating. A couple of aspects as far as termination of resuscitation, as you mentioned in one of the slides, that this is one area where the evidence is least. What would be your recommendation that whether
You
we
have
should
to change your mic for the phone or anything. You're not very much audible. Okay.
Yeah, can you hear me?
We
Better,
can
sir.
hear you, but very, very low voice.
Yeah, any quick comment on termination of resuscitation? That means in Western world, it is somewhere between 20 to 30 minutes. One of the BMJ literature suggested 20 minutes. The ECPR guidelines say that now if you are not able to restore from 20 to 30 minutes onwards, you should start preparing on ECPR. So your quick comments on that.
Right. So that's why my first slide was the important slide, because all the explanations are based. The cardiac arrest has three phases: electrical phase, then starts the ischemic phase or the hemodynamic part, and then the metabolic component. So basically, if we don't have an organized rhythm for almost 20-30 minutes, this means the metabolic phase is already initiated and the ischemia has been started. But remember, we also need to understand that in certain situations, if we are doing a good quality chest compression, the perfusion of the vital organs are happening. And if you have underlying reversible cause, say for example, hyperkalemia, say for example, if there is some issues with regards to the glucose level, if they are reversible causes, those needs to be reverted back. Pneumothorax, pericardial tamponade, these are the reversible causes. So we cannot say that the time is only the factor for termination of resuscitation. We should make all attempts to find the reversible causes, which is hit the target. And that's why the team approach, team dynamics becomes important. And from the second, third, or fourth cycle itself, a team member should start emphasizing and ruling out or ruling in, hit the target. And once we have done it, once we have tried to revert it that the potassium is lower, glucose is okay, urea creatinine was not a big issue, chest expansion is okay, maybe POCUS or clinical examination appears to be okay. Once we start ruling them out, then we can say that if you are not able to see an organized rhythm in a good quality CPR of 20-30 minutes, we can terminate the CPR at this point of time. But then we all again have to look for, now we have many studies simultaneously, those patients who are cardiac arrest ectomy in a lower temperature on mountains, they can survive for long. So that also needs to be taken care when we are looking for decisions. That's why majority of resuscitation councils, and especially the ILCOR signs, does not specify a time. They just say individualize, reverse the reversible causes, and probably 20-30 minutes, probably ischemic injury and metabolic changes started. That's the time you should take decision what to do. They don't say stop CPR, decision what to do next. And one decision would be stop CPR.
Yeah, just to add to Dr. Rakesh, that
Yes, sir.
the primary problem of a patient is also important. That if a patient for 2 months, multi-organ failure in ICU as a cardiac arrest, and a young guy who is just 30-year-old and has come with acute coronary event, so these will be the two different, because causes of cardiac arrest are many. So we have to decide on individual basis that this guy, I will do CPR for 1 hour for a young guy till the time I'm bringing him to the cath lab and we are trying to open the vessel if it is possible. So there, even when our CPR will be worth doing, but for a patient who is a multi-organ failure for 2 months in ICU, you do 10-20 minutes, and then definitely you can discuss with the family council and you can stop the CPR in those conditions. Any other question?
The role of lactate you will consider in
Yeah,
termination?
definitely, sir. I think lactate is one of the important marker. When we talk about the post-resuscitation care, definitely it will remain one of the good marker to look for how the patient improves upon. But as when the ongoing CPR with compromised perfusion, I think it may not be acute marker during the CPR, but definitely a very good marker for post-resuscitation care, apart from other parameters.
Yes, Dr. Chetna, you have raised hand.
Yes, sir. Good evening. Very well presented, sir. I have one query. Could you please explain the stacked, single, and dual shock again?
This is what is coming up. When you give shock, if you give a single shock, we say it's 120 joules. If patient responds, good. If patient do not respond, still have arrhythmias like ventricular fibrillation, your next shock should be 150 joules. Even if does not respond, next should be 200. Now, this is what the recent science or the guideline says. Now, what the recent science is emerging about it, that if the patient is not responding, still having arrhythmias, especially VF, and is not responding to 200 joules, this means 200 joules is less for reverting those rhythms back. You can go still higher till 360. So this is what is emerging. Second thing is, now earlier it was, if you remember, around say 15 years, 10 to 15 years back, you give one shock and then immediately give second shock at the same point of time. So there was some gap in between. This is so-called dual shock. Now what we are doing is now the most recent one, and the paper has coming up, even the ILCOR has recommended it, that if you have two defibrillators, you can attach both of them and give energy from both of them simultaneously, because when you give a stacked defibrillation, there will be some time gap, and we don't want those to happen during the resuscitation. But now this strategy, I will share the paper, the whole paper into some of the groups after this class. So in this area, you can use two machines and give dual shocks to these patients, giving them high energy if patient is having refractory arrhythmias.
So what should be the joules set in both the defibs?
It will be around 200 joules, so it will go up.
Okay. Thank you, sir.
Thank you, ma'am.
Any other question? Yes.
There are a couple of questions
Can I ask you
in the chat box.
Okay. I'll just check it.
Vivek, can you listen to me?
Yes, sir. Yes, sir. I'll read. Yes.
I just checked my voice is
So
coming
there
on.
is a question. My question is do we have to stress more on the feedback device while training during the chest compression? What is your take, Doctor?
I think I fully agree, and also when we say feedback must be there. Now there are two ways of giving it: manual feedback, human feedback, and feedback device. So I think manual or human feedback must always be there. It is always suggested that feedback devices which comes with equipments is always good, because finally we are talking about high quality CPR. And in fact, it is not just for training purpose. Now we have those devices which are available for patient use also. So if your infrastructure and financial things apply, they permit you, why not to use it for real-time CPR also? So I fully agree. Wherever possible, use it. But it will be too difficult at this point of time to say IRCF to make it mandatory because of financial constraints. But yes, it is highly suggested.
Okay, there's another question. If some ventilation is occurring during chest compression, should we ask to turn neck on one side for better ventilation?
I could not understand. This means turning the neck on the sides.
Yeah, if some ventilation is occurring, means how it is
Yeah, I don't think
possible that the
Airway
patient
will be-
is
airway will be obstructed when there is cardiac arrest because of the muscle relaxation.
Yeah.
And if we turn on one side, then airway may be patent and better ventilation can occur.
So turning neck is not the option. It is the lateral position of the whole patient that makes the airway patent. If you turn it on the sides, neck, there are two issues. One, if it is a fall, it can lead to more injuries. Number two, it will not be any helpful, not for regurgitation. It will further blocks the airways. What you need to do is keep the patient in neutral position and ask one assistant to keep the airway patent. So you can use the oral airways if available for these patients. Turning on the neck is not suggested, sir.
another question, Dr. Rakesh. Dr. Srinivas has written that usually a question comes at compression of 5 centimeter, not more than 6 centimeter. So how to do in victims? How we know our compression is 5 centimeter?
So this is primarily the training that we provide, and that's why we say that each one of us should be trained for the courses. And when you go for the courses, and when somebody just mentioned about the feedback device, one of the feedback is the speed and second is the depth. So this gives you feedback. So that comes with training. And approximately it appears to be the 1/3 of the height of the chest. So the person who is observing the chest compression happening, and that 1/3 of the chest of the patient is compressing. And that's why we encourage to keep some hard board below the patient so that actually it translates into 1/3 of the height of the chest being compressed. So this is by practice and by a person who provides the cue or the feedback, which was just talking about maybe the human feedback for a good quality chest compression.
There is two questions related with the.
Yeah, one question can I ask you, sir?
Yeah, please.
Sir, this is Dr. Ravi. I'm
Yes,
audible,
please.
sir?
Yes,
Yeah,
yes,
you're audible.
Hello.
Dr. Ravi, you are audible.
So I'm audible. Yeah, sir, I have a question to you. You said that this keeping the pads, 2 machines a single time on a patient chest can be applied. How can this chest pads can be applied at a single time, sir? 2 machines of pads can be applied on the patient chest.
So I just posted this paper onto your YouTube. I'm just posting the link also. This is one of the paper which has nicely been paid. So this is, there are two separate set of pads that are attached here. I will share the picture also in the chat itself. Just
No,
go
sir.
through that.
My question is how the pads can be applied in a single time because the position is
Yes.
there. There's a right side pad, left pad, left side. Then how the
Yeah, yeah.
2 machines pads can be.
So you have to change a little, change the position a little bit. It can be having a little difference of some space in between. I'll just share it.
So then that the sensor will catch up, sir, identifying the shock is required and the shock is not required.
No, this is about the defibrillation. We are not talking about the AED here. So this is
Okay,
for
manual
defibrillation
defibrillation.
in
You're talking
hospital.
manual defibrillation, right?
Defibrillation. So you
Okay,
have
right,
to
sir,
see
right,
that
sir.
rhythm is a shockable rhythm, and then you have to give it.
Yeah,
while
I understood, sir. I understood it. So one more question can I ask, sir. One more question. It may not be directly relevant to CPR and AED, but indirectly is related. How much time a cardiac arrest patient can be conscious after cardiac arrest?
Usually it is just matter of seconds, sir. You must have seen the vasovagal syncope. So it is usually a few seconds. Patient can sustain consciousness without perfusion of the brain. It's not more than few seconds.
And so finally, one more question, sir. What is the best AED for non-medical people we suggest for the companies or the other industries? Which is the best AED machine you can give a good feedback or give the shock? Can you suggest which is the best AED?
I think IRCF is neutral with regards to the company marks, sir, but you can just see for the specifications that these patients have.
Choose by yourself. There are many companies within India and abroad. There are advantages and the price factor also.
Thank you so much. Thank you so much for your valuable information. Thank you so much. Thank you so much.
Rakesh, there is a question on biphasic and monophasic. Can you just clarify this?
So when we say about biphasic and monophasic, these are basically the electrical current that is being delivered by the machines. So those are the properties of the electrical current, like you must have seen the DC shock and all those things. So when we say monophasic, this means the current delivery in monophasic is usually less efficient, and that's why we have to give higher energy. Biphasic mode of delivery is more efficient, and that's why we can decrease the current. If you remember the older guidelines, when we were having our monophasic defibrillators also, they are not being manufactured nowadays. But if somebody is having very old one, the monophasic used to be say 360 joules, biphasic we used to say 200 joules, 120, 200 joules. So the biphasic is more protective because I mentioned the current will be delivered the same, effectiveness is decreased, and the damage will be more. And that's why the monophasic has been almost discontinued from the recent guidelines. And similarly, even the manufacturers are not manufacturing it.
Not available.
But if somebody has used higher, use biphasic because they will be efficiently delivering the energy to the heart to revert the arrhythmias into a normal sinus rhythm.
Right. If there is no more question,
Sir, good evening, sir. I'm Dr. Pandu Nayak, CRTC coordinator from Usmania Medical College. So it is not the question, sir. The only I want to give the feedback. Recently, we have started CRTC center at Usmania Medical College under the guidance of Dr. Chakra Rao sir and Rashish Diwan sir. So 28th of April, we got training pool of TOT around 40 participants in Usmania Medical College and medical colleges from Telangana. So within 1 month period, 1 month and 1 week period, we trained 300 postgraduates, all the specialties. So in BCLS and CCLS, the feedback what we are getting is very good feedback, and with that, our faculty members of different specialty, they also wants to get trained for this in this training. So it is very effective program, sir. So it is going in a very good way. So this with this spirit we'll continue, and we want to train all the other postgraduates of other medical colleges other than Usmania. All the government and private medical college PGs has to be trained, and house surgeons also, because as it is a mandatory, it is required for all the PGs and house surgeons. So we are doing under the guidance of this, and I thank the team who came to Usmania Medical College as a TOT teachers, Dr. Vivek and Dr. Srinivas Rao, Dr. Subramaniam and Dr. Hemant. So thank you very much, sir. This is my feedback.
thanks, sir. Dr. Rakesh, there is another question. Can calls advisable in pregnancy?
CPR is advisable to all the patients irrespective of age, gender, clinical condition, everything. Only situations where you don't do CPR is when you have rigor mortis or a situation where you think is an end of life care. So I think this is just, I will take just 30 seconds with permission, Dr. Vivek. There are certain situations, the ICMR has brought up a guideline, which is end of life care, where you say do not resuscitate. So we should also be a little cognizant about this fact now, that a person who is not salvageable, say for example, advanced metastatic cancers, a patient with terminal renal failure, a patient with terminal cardiac failure, not amenable to cardiac transplant, a patient who has, say, decapitation, a patient who has rigor mortis. So there are certain situations wherein you will not do CPR. So this is called a good document by the ICMR. Do not attempt resuscitation. Otherwise, if you think patient is salvageable, all patients, irrespective of anything, should be offered CPR.
Thank you,
But
sir.
because in drowning, we say that instead of only COLS, BCLS is more effective. So that's why in pregnancy, if they are more susceptible to hypoxia, will the BCLS be preferred?
So I think the point is very clear. COLS is only for layperson, non-medicos and non-paramedics. BCLS is for all the persons in limited infrastructure. Suppose if I go outside the hospital and found something, and if I don't have anything, probably I will only be doing COLS there. Moment I get AED, we can add on, and that becomes BCLS. So don't try to have confusion between those aspects. COLS is for lay person doing CPR. That's why I was emphasizing in the beginning, please do not teach lay person checking pulse, breathing, and other things. I did a study of our college students in Delhi. We have taught almost 1,100 college students in CPR, in which we have divided into two groups. This is unpublished data, and we were teaching them breathing also, and they were college students. And we realized that the first chest compression took place almost 6 to 8 minutes later, because they were so enthusiastic to give breathing, and most of the breathing were ineffective. And I mentioned that 6 to 8 minutes is pretty long time for giving a chest compression. This delay is pretty long. And that's why across the globe, I'm repeating it again and again to all the listeners today, and very humble request, please do not teach breathing to the laypersons, please, because you will not be able to teach it. I remember my postgraduate days, it took me almost 10 days, 20 patients on practical, my teachers teaching and BAMC to learn an effective bag and mask ventilation. And still today I face sometimes a difficult bag and mask ventilation. Today I sometimes even feel it. How can we teach breathing to a layperson? So please do not encourage breathing to a layperson. It can be taught to paramedics, and that's why BCLS is absolutely different. So don't mitigate or don't combine two separate algorithms. We have really worked hard. They are internationally acceptable. So don't try to mix up COLS plus BCLS, BCLS plus something. They are dedicated guidelines. If there are some changes come up, we will bring it. Right now, only one change which is supposed to be there, that in those states where AED is available, we will be integrating AED with COLS. The rest of the guidelines absolutely remains the same.
Very clear, Dr. Rakesh. Thank you very much. Dr. Rakesh will be available to answer all questions in the chat box. And thank you, Dr. Rakesh, for a wonderful discussion. Over to Dr. Chakra Rao sir and Mukul sir.
Thank you very much, Dr. Rakesh and Dr. Vivek. It's a wonderful discussion. Some of the points actually we have been repeating many times, but I request of us, we have a different gathering. I feel that we should have a regular monthly webinars like this, so that we can educate ourselves and it will help us in many ways. Definitely, we have about 7 members from India and the IRCF who are writing the guidelines for the ILCAR, and we are at par with anybody, or even if you follow the trainings, I think sometimes we are much better than the many of the registration councils. Thank you, sir. I think we can proceed to the next. I think I can request Dr.
Sir, Dr. Baljit.
Good evening, Dr. Vivek. Thank you so much. Well, friends, we have had a wonderful session. It was kind of a master class. And what was the best of this particular session was that whatever doubts that people had, I'm sure the way Dr. Rakesh Garg explained, these are put to rest. And a lot of clarifications which were required. So these have already been answered. And if there is anything else left, I'm sure Dr. Kesh will, be in touch with them later on also. You can put it in the chat box. You can write to him directly. So he's so approachable and he will do it. Friends, the session was so interesting that nobody looked at the time. We are way, behind the actual time. Let's keep that apart. So the next session that we have is on how to become the CPR instructor facilitator, and start comprehensive or CRTC center at different places, because a lot of queries are coming from different areas, from different people in different states as well. That we want to start a CRTC center, or somebody wants to become a IRCF instructor. So to give information about these, we have one of the best known name, apart from Dr. Shakra Rao, Dr. Sesh Diwan. Dr. Sesh Diwan, again, I think everybody knows him so well, a very gentle, affable, pleasant person, extremely nice personality. He is 24 hours into IRCF activities, just like Dr. Chakra Rao. So he's the director of.
But Lokesh is also there with you, Dr. Lokesh is also there.
Yeah, but
Lokesh is there?
I'll come to him. Yes, he is there. At the moment, I can't find him there. Anyhow, so Dr. Rasesh Diwan is there. He's the director of training and education for IRCF, the national director. And he has traveled extensively all over the country, doing courses here, doing courses there. And I think I'll not stand between him and the presentation, between you and him. So I will pass on the mic to Dr. Rasesh Diwan now. And if Dr. Lokesh Adara is available, he can say a few words before Dr. Rasesh Diwan takes over. Dr. Lokesh, are you there? Dr. Lokesh Adara has joined us from US all the way. It must be early morning there, and I'm sure he would be busy, to start his day. So I'm sure by the time the session is over, he'll be available. Over to you, Dr. Rasesh Diwan, please.
We can, Lokesh is not there, I think.
Yeah, I can't find it.
We can proceed whenever he comes. He can.
Yes, sir.
Thank you so much, Dr. Baljit Singh. Am I audible properly?
You are,
Yes,
sir.
sir.
Yes, sir. Thank you so much, and good evening, everyone. And I'm sure we have been delayed a lot in the schedule. And Lokesh gave a wonderful time in the morning, but this is the time when he started probably working. So he must be working, and he may join anytime during the course. But I must appreciate his zeal, and he had been a mentor and advisor to all of us for the Indian guidelines for many, many years. And he had been an advisor for us and felicitator for getting us into ILCOR. So we must thank him in his absentia. I thank him a lot, and he's always helping us a lot. Thank you so much, everyone. And we had a wonderful presentation from Rakesh. This was about the science of resuscitation and what are the evidences. Now we are twisting the presentation to more of an administrative side of the IRCF and the creation of the center as well as the faculties. So I'll be talking more about the administrative side, and I'm sure that, as Dr. Baljit Singh said, there are so many questions coming up about all this, and there's a lot of myths and misunderstanding about the functioning of CRTC and functioning of faculties for IRCF. So I'll make a humble attempt to clear all those doubts, and we can cover up with the questions, not even if we are short of time, even later on. As you say, 24 hours. I don't work for 24 hours, but I'm always ready to answer the queries about the CRTC and creation of the faculties. So that's the agenda is two aspects I'm going to cover. The process of CRTC, which is known as Comprehensive Resuscitation Training Center. And second is the process of making an instructor for the IRCF. So these two aspects, I'll first begin with the instructor facilitator for IRCF. So the objective of my presentation is for CRTC. What is CRTC? What is the role and responsibility? Who is the CRTC coordinator? What are the functions and to whom they report? And second aspect of the lecture would be IRCF instructor, how to be an instructor, what is the process for becoming a successful instructor, and what are the role and responsibilities. So I'll first begin with the instructor's aspect. The CRTC I'll cover later on. So let us understand what is the role of an instructor. First of all, most of us are teachers. And we've been teaching in the medical colleges, also in the conferences and academic events and workshops and everything. So why there should be a process for becoming an instructor? That is the major question we are getting very frequently. So we learn from the book, and why I need to not be teaching next day when I have finished the curriculum in the textbooks. So that's the process we must understand for becoming an instructor. So Rakesh has been teaching us a lot for last 3-4 years. What are the characteristics of a good teacher? So let me briefly cover that. What are the characteristics of a good teacher? So it's a passion. First of all, it inspires students to learn and engage actively in the learning process. So that's a passion to be there in an instructor. For that, he must have the deep understanding of his subject and teaching methods and strategy, how he will handle the students and how will percolate down his skills and knowledge to the students. Then comes the communication skills. He communicates effectively to the students in the level of his understanding. This is what, when I say, when we teach comprehensive kind of life support, if we have the intensivist and specialists, it is different. If you are talking to the nurses in ICU, it is slightly different. But when we took to the undergraduates and postgraduate students who are the clean slates, where our passion and our communication skill is slightly different, and we discuss a lot about the rationals and why we do this, and try to write the correct things in the clean slates. Then comes, he creates a supportive environment for the students with empathy and patience. This is very important when we are dealing with the particularly undergraduate students and fresh postgraduate students who are in a process of becoming a consultant or maybe coming in the teaching lines, because this is very important that we have an empathetic approach to them. Teacher has to be an adaptive, and he changes his method according to the diversity of the students' level, their basic level. So that's why he has to be very vigilant in how he handles the students and find out the lacunae and put it properly. And he has to identify in a classroom of, say, 24 or 30 students. Some are shy, some are aggressive, some are dull, some are non-attentive. All this he has to be identifying them. Our aim is not to pass or fail them. Our aim is to make them understand and learn the subject properly. And we have to be selfish. When I teach resuscitation, I see that all 24 people learn the same. Suppose I collapse in his presence, they will do at least a very good job for me. So that's how he has to be very adaptive in what he's doing. Then he has to be very positive in his attitude to create the growth of the students. So he has to understand the students and work very hard with a very positive attitude. He has to be creative. Creative, when I say, means he has always generates curiosity among the students. And I believe that we have to make them hungry to understand. So make it very interesting, generate curiosity. And I always say, when there's a closed loop discussion going in the classroom, which is disturbing, but it is related to subject, that means you have created an interest among them to discuss. And that is what happens when they're doing the tea time or lunch time. They ask the question, that means you have generated enough curiosity. So that has to be the creativity which every faculty member has to create among themselves. Then respect and integrity. He should treat the students with a lot of respect and integrity so that they should never ever feel offended when they are learning. If they are shy, if they are dull, if they don't grasp, respectfully and make them understand, and they open up well along with the teachers. So he has to be very open with them and respect the students. Good teachers always pursue improvising their skills and knowledge. So it is a continuous process. And as an administrator of the classroom, he has to have an organization skills to decide the skills, how to percolate down to the students, what are the equipments required, and what activities which takes place in the classroom. So this is what are the characteristics of good teacher, which applies to any teacher in the college who are been teaching in the medicine faculty. So good teacher means a positive impact to the lives of their students and help them succeed academically and even in the personal life, being a good human being. That's the characteristics of a good teacher who brings this very positively to the students. But now coming to the resuscitation science, there has to have some additional characteristics to the students, because when we teach the resuscitation is a very sensitive subject, and the process of making the faculty for resuscitation is a very dynamic process, because its skill is taught for the survival of people who are about to die or impending death is there. So it is for saving the lives. And these instructors, when we come with the strategic thinking and you have to work in the frames of seconds and sometimes 10 seconds, 20 seconds time, instructors have to be highly competent and capable to share knowledge and skills. So there's an additional feature required for training for the people who are resuscitation. To teach a classroom, a theoretical lecture, you prepare well, you make your presentation and you talk, you rehearse and do it. But when we are teaching the resuscitation skills in the workshops, it requires an additional skills. And this, as which I have tried to put some of the things which will appeal all of us for the instructors, is it ensures high standard of training to maintain the quality of accuracy in training. And I'm very happy to have Dr. Baljit Singh chairing my lecture. He has been talking about the quality of training a lot in all past online TOTs we have done. So there's a lot to learn from him. And every time when I listen few good words, which helps us to percolate down the quality of training. Next is the competency and the confidence in training. That is very much necessary, because when we give a case scenarios and students talk something wrong, he does something wrong, we should be competent enough to find out what he has done wrong, and immediately with the confidence you have to rectify it. And at the same time, sometimes you have to give the rational. Third point is the consistency of training. Irrespective of the faculties, all faculties should maintain the consistency. So even if you are not there someday, the other person does the same thing and he maintains the same consistency for future courses also coming every month or every 2 months happening in your institution. Nowadays, NMC has given a guidelines to train all the first year postgraduate students with our guidelines. So it has become a very mammoth task for us to create these faculties with that power, that training, that efficiency and consistency, so that the motive and everything is not diluted, what IRCF has been trying to establish for last 4, 5, 6 years. Unfortunately, we lost a lot of time in the COVID time where we could not progress well to train more. But last 2 months, we have been successfully making a lot of trainers, which will give the same consistency of training. Simultaneously, all the trainers has to be updated with the guidelines. They have to read a lot about the science, because we talk only about the skills in the workshops, but they have to have the knowledge and a lot of theoretical knowledge by getting from the library, from the literature published, by attending the lectures and CMEs and webinar like what Dr. Rakesh talked today, and Dr. Said Moid has been talking about this also a lot. And we are so fortunate that now we are upgrading the guidelines, and which Dr. Rakesh, Dr. Said Moid, Dr. Mukul Kapoor, and Dr. Baljit Singh, and everyone prepared before 6 years. We have a young brigade coming up with Dr. Vivek and Dr. Binil, and so many other people who are going to help us out to create the newer guidelines. Now, one more thing which I want to tell you, which increases our esteem, is the formal instructor certification provides the recognition and as of all the faculties. But that gives the responsibility of maintaining the quality of the course simultaneously. So it gives them credentials, it gives an esteemed position, also gives a responsibility and to maintain the course. There is a skill development which takes place with the process of becoming an instructor, where how you train the students, how you identify weak students, how you modify your technique, how you assess the students, and how you give a feedback and do debriefing. And at the end, you create a wonderful trainers under you. So that's a separate skill which is necessary for particularly when you are conducting the course. And that's how you learn the skill of evaluating the students and provide them a proper feedback and to rectify the mistakes, because the mistakes made in resuscitation are always at the risk of somebody's life. Most important thing which I want to tell to all existing instructors also, please create a faith and, and develop your commitment for our own guidelines, our own Indian resuscitation guidelines. This is very, very important for all of us to understand. So what is necessary is when we make an instructor, there is a structured training process is necessary, and resuscitation instructors help ensure that individuals providing this critical training are qualified, knowledgeable, and able to instill the necessary skill and potential for life-saving situations to our students. So for that, a process is necessary, which otherwise sometimes people ask why we need a process. We learn from the books, we gather all the information, but you must understand that even when you are conducting the course, it is not that knowledge and information your aim is to transfer to the students. They are supposed to read it before, because we have provided them the manuals before and they come well read, and probably in short time we'll have an online pretest also available on the website. It is the skill which is important we want to transfer, and we concentrate more on the skills, and that's the reason for the faculties we need to have the instructors process. So the process is when you want to be a instructor, first step is you must do a BCLS CCLS provider course. This is the first step, and the instructor potentials, those who want to be the instructor in future, has to pass the test with 90% marks without remediation. So there is an important criteria. That means you are capable of understanding every word spoken and every skill taught in the classroom and to get 90% of the marks. And with the remediation, if you do, that means there is some lacunae which you have failed to understand when your faculties were talking to you. The course directors and the faculties judge for the instructor's potential, and they put a note in the website, in the server, and that this particular candidate has instructor potential. So that is a judgment made by a very knowledgeable, experienced course director and other faculties who are you are attending in the course. So the important thing is the first step can be bypassed for those who are existing active instructors from any international equivalent resuscitation council guidelines. So this can be taken care provisionally if they are active, say for example, AHA instructors who are active, or those who are European Council instructors or equivalent, which are part of the ILCOR members. So for them, we can bypass this first step and straightway do a training of trainers program. Now, all those who have undergone the first provider course and have
Dr. Rasesh, you have gone offline.
He has left Zoom call, I think.
Kindly check your audio visual.
Sir, he will not be able to hear. I think we have to call him and tell him.
Okay, I'll do that.
Sir, you are off the line. Oh, you join in again. Yes, everybody is on. I'll send you the link again. Please join. It will show me. And somebody is interrupting and all those things. Please join, sir. Try to join it. What should I do? Send you the link again. You have the link.
Sir, Dr. Shankar Rao, I've just spoken to him. Please send him a link to rejoin. Dr. Shankar Rao, sir.
Yes, I'm sending again.
Can you do that? Can you do that?
Send you the link again. Please join on the new link.
मीटिंग चालू है क्या है जूम कॉल है
Hello, this is Dr. Lokesh. Sir, can I
Good evening, Lokesh. Actually, there is an interruption.
Yeah, I've spoken to him. He has got the link. He's joining.
Yes, now
he'll connect.
Yes, connected.
Sir, meanwhile, we can take up the questions, sir, if any.
Yes.
Yeah,
I'm back.
Good idea. Do you find any in the chat box? I'm sure people would not have put up the questions there so far. I think there is Dr. Diwan. Yeah, there it is.
Am I visible and audible?
Yes, sir, you are. Kindly make it full frame. Yeah, that's right.
Yeah.
Fine.
So what I was talking about, once you are through the provider course or you are exempted the provider course, you have to join a training of trainers program. This should be joined by instructors, potential candidates if they wish to, but must have the faith in Indian guidelines. There should be some commitment and devotion and passion and aptitude to teach. So this is very important to understand before you join the trainers training program. Now, trainers training program includes what? It includes the method of adult teaching, which Rakesh and other people are doing their excellent job. Then there are FAQs and evidences, which we talk today and we talk elaborately at that time, because that's the time we don't share any academic knowledge. It's the rationals we discuss and we discuss the skills. And there's a lot of micro teaching and assessment of the potential instructors with teaching skills. So we give small topics that time. They give a presentation and all senior faculties who are present there with the course director assess them. A formal test is done, practical evaluation is done, a skill demonstration skills are given, one topic to each person. And finally, when everything is done, a formal test is done, and they are given a provisional certification that you have undergone the training of trainers program. Then the process doesn't end there. The process starts further. They have to join some of the CRTCs, and they have to carry out 2 observer instructor sessions. The observer sessions are there when they are provisional faculties, and the potential instructors are allowed to teach under a course director and other faculties. There is a debriefing done, there is a feedback taken, and guidelines are given. They are being rectified, their problems are being solved, and finally the CRTC coordinator or the course director recommends the instructor's name to the national headquarters. Now, certification of faculty is always through the national headquarters, and once on the guidelines from the CRTC coordinator for the potential candidates who have done 1 or 2 observer instructor sessions in the full course, they are being certified as a faculty. Now, these instructor certificates are valid for 2 years. They have to teach at least 2 BCLS and 2 CCLS courses in 2 years and keep a record forever. And this record helps us for renewal of their certification after 2 years. On failing this, they have to repeat the process. And they may have to undergo the TOT or maybe have to undergo the provider course. And in between the guidelines are changed, they have to attend the change of guidelines, webinars and CMEs and get updated. There's a moral binding that the instructors cannot use IRCF teaching material for any other training except IRCF training. They cannot alter the presentations which are copyrighted. So that was all about the faculties. And time and again, if anybody has any query, I will be able to help you out to how to manage their instructor certificates, how to do the renewal, and how to become the instructor. Since that, we have a mammoth task of training a large population in our country. We have made the process of making an instructor very robust, very elaborated, and it has to fit to all the international council guidelines which are being existing across the world. So we have to follow the same criteria for making the instructors. Now, briefly, it is getting very late, but I'll talk about the CRTC also. So CRTC means a comprehensive resuscitation training center is the functional unit of IRCF. It works autonomously under IRCF, follows all the protocols and as guided by the IRCF. There is a CRTC coordinator for every CRTC.
Oh, no, I think there is some problem with this connection there. Let me speak to him.
Sir, he's connected. I can see him connected on the second there. I can see Rashesh the one sec.
So there's some problem with the probably it's raining outside.
Okay, now that you are connected, sir, please carry on.
Can you see?
Yes, sir.
Okay, okay.
Full frame, please. Yeah, there you are.
So there is a fixed role and responsibility of CRTC and CRTC coordinator, and he is in charge of the whole process of conducting the courses. So who can create a CRTC? Any medical college, dental college, nursing college, any hospital, any city branch of medical associations, any NGO or academic skill labs who are involved in therapeutics or in medical management or in the medical skill labs, we give a permission to create the CRTC. They require an infrastructure which has primarily a skill lab, and motive is to train the skills to the students. So this is very important that we have an adequate skill lab, which as per the guidelines of IRCF, which is mentioned on the website also. And the infrastructure has to be depending on the course. Suppose you are only training basic cardiopulmonary life support, the equipments are less, which is also written on the website, and you can get all this information from there. But you have to give an assurance to acquire the during the course if you do not have certain equipments and we are intending to conduct that course. That is happening at various places, and they hire it or they get it from somewhere, or they borrow it from some other institutions. You have to affiliate at least 6 faculties for every CRTC. The faculties can join multiple CRTCs, but CRTC, one coordinator can make only one CRTC he can handle. So this is what the rule IRCF is bringing. The infrastructure should have the lecture hall with the floor space for carrying out the hands-on training, audiovisual facility, internet facility, office equipment, office staff with good computer acquaintance, adequate floor space for hands-on training, equipment storing capacity, and proper catering and utility services and safety measures all has to be looked after by the CRTC coordinators for the courses. Now, the function of a CRTC is that organizes and conducts the courses which they have been permitted to do it. Some are given all the courses, some are given only BCLS as per their infrastructure. And they have to follow strictly the IRCF resuscitation guidelines. They have to affiliate these faculties who are certified by IRCF. They have to keep the records of the courses carried out. They have to maintain the records of instructors who have participated in the courses, because that count is made and that helps us to renew the instructor certification at the end of 2 years. Every CRTC has a back office on our website. Website is www.cprindia.in. And on their back office, they have their own login details. It's a very complex website. If you're not looked into the back office, please go to it and you will see how complex it has been made. All the records are stored in a specific manner. They have to create the batch, they have to create generate the courses, and all CRTC details are available for that particular CRTC on their back office forever. So, for applying to CRTC, they have to write to the chairman, and the email address is nhq@cprindia.in, and provide the details and assurance about the infrastructure as well as the guidelines available on the website. Create a memorandum of understanding with IRCF and CRTC organization, and there's always an inspection of proposed CRTC from national headquarters, which you have to fulfill the norms which are guided by the national headquarters. A coordinator is in charge of the CRTC. Coordinators are visible on the website with their contact information. So if you want to check your CRTC, you go to the homepage, go to the CRTC center locator and find your details. Any discrepancy is there, please write to the admin officer and get it corrected. The CRTC coordinator always reports to the IRCF national headquarters. The role and responsibility is in charge of CRTC. He coordinates. Creators are visible on website. This is what I already said before, and they report to the national headquarters. They conduct and coordinates IRCF courses as per the guidelines of IRCF, enrolls the IRCF certified instructors, allocates the teaching assignment to the instructors, maintain the quality of training, maintains the confidentiality, abide with the privacy policy of IRCF, and updates the guidelines whenever recommended by IRCF. He is the sole authority of a CRTC center. When he generates the course, he acquires the manuals from the national headquarters well in advance and create a batch on the website. Once he creates the batch, it is visible over on the home page also that in the future courses coming up, and enrolls the instructors and assigns them the teaching roles. He distributes students the manuals well in advance so that they are well read before they come to the course. So the theater aspect can be cut short a little bit and more time is devoted for the skill training. The CRTC coordinator supervises the course proceedings and takes the examination, does the remediation, and makes the result and generates certificates and deliver to the successful students. The office executive, we have Mr. Arun Kumar. He assists during all the process of CRTC. So he helps us out to create the center. He helps in delivering the manuals. He helps for creating the batch initially till the CRTC coordinator and his assistant picks up. So he's always there. Rather than me, he's working 24 hours. So I'm very much thankful to Mr. Arun Kumar. I'm sure he is attending and listening to us. The CRTC is the backbone of IRCF. They are the functional units. So you have to follow the guidelines and you have to work with you have to align with the principles of IRCF very well, and you have a tremendous role to play in process in making the courses happening and the success of the training of the students all across the country. So if I summarize, the instructors are the family members of the IRCF. They are potential task force members. So you work hard and see that you someday you are in the list of authors, you are in the list of the task force members, and you are the future and replace all of us to carry out the IRCF motive and guidelines forever. They have to maintain the sanity of the IRCF. They have to be affiliated to IRCF. CRTC has to function with the motive and principles of IRCF national headquarters. So with that, I would like to end my presentations. I'm sure the time has gone a lot. We may not have many people probably attending, but if any questions are there, you can ask me, you can ask the panelists, you can ask all the senior people.
Thank you so much, sir. I'm sure with this presentation, whatever doubts the members would be having with regard to how to become a instructor, facilitator, or how to contribute to IRCF activities, I'm sure the doubts would have been cleared. And you also have mentioned very well about how to start a CRTC center. I think everything has been very clear. If there are any questions, I'm sure Dr. Diwan is always there. I invite Dr. Lokesh Adara to say a few words. If he's
Has Lokesh arrived?
Yeah, he's there. He's connected, but maybe he's in the process of starting. Beginning his day, so he may be off the computer at the moment. Anyhow, whatever other questions, please put it up. You can put it in the chat box. You can raise a hand and then ask question to Dr. Diwan.
We need a resuscitation department,
Yes.
full-time 2-3 instructors in a medical college. In United Kingdom, Oxford has it all done. Yeah, that's a good suggestion. We should.
It's from Dr. Lokesh Adara that I see. There was one more query. We have a couple of cardiologists and cardiac anesthesiologists who have been regularly attending our courses. Couldn't get TOT done for them. Please guide on how to proceed. So, Dr.
So good
Diwan,
evening.
you can
So good
kindly.
evening, sir. Rajesh, sir. Dr. Vaidyanathan here.
Yes, sir.
Can you hear me, sir?
Yeah, please, sir. Go ahead. You are audible.
Yes, sir. Yeah, I put out that chat message, sir.
Yeah.
Currently, I have got 3 or 4 instructors, sir, who have been regularly doing the courses. I think sometimes I find it difficult to get instructors from Bangalore. Only Chandrika madam is there, and gets little difficult. As you may be aware, probably we have to conduct it for postgraduates regularly. We have got a couple of cardiologists and cardiac anesthetists who are regularly attending our courses, who fulfill all the criteria to become instructors of IRCF. They are passionate and they believe in Indian guidelines, and they are very well aware of our guidelines. I want to know, like TOT, they couldn't do TOT last time, sir. I want to know how to proceed to add them to the instructors.
Dr. Diwan, I can see that I think the rain is playing havoc with his connection over there. So, Dr. Chakrarao, would you like to take it to over?
Sir, is not there.
Dr. Vivek, can you come in? Kindly unmute yourself.
Can you repeat the question, please?
We have a CRTC, sir. We have been doing CRTC courses regularly. What I have is currently I've got only 3 or 4 instructors. We are the only center in Mysore. What happens is when I have to do courses from Chamarajanagar and other medical colleges or sometime, I have to rely on instructors from Bangalore. So with regular our 4 to 5 instructors, what I have, I need at least 2 or 3 more instructors to be added to our CRTC. What we have is I have got a couple of cardiologists and 2 cardiac anesthetists who are very good and who have been attending our courses regularly. The thing is they have not undergone TOT, sir. Like I just want to know how to add them to our instructor list.
See, Dr. Dewan has clearly said that we have to follow certain norms. And one norm is if someone is the AHA or any other certified guidelines instructor, He
Yes,
can be
sir.
taken directly, go for the TOT, and he can become an instructor. But if even a cardiologist or cardiac anesthetist, they may be very good, there is no doubt about it. But at least they should follow the structured training course. At least they do a provider course followed by an instructor TOT, and then they can become instructor.
No, they've done courses. CCLs they have done. They have been
Yes, so
attending.
then they can
Thought,
join any TOT
thought
course.
they couldn't do actually because I couldn't get them to do thought recently because it happened quite some time back. So during the earlier thought, we added around 11 to 12 instructors, and they have been with me. Because the programs are getting a little busier. We have to do so many programs recently. So I just wanted to know whether I can, whoever
Yes,
is
they
there,
can become an instructor. They can join a TOT and they can become an instructor. Absolutely
when
fine.
the TOT,
So what?
when it will be
Sir,
happening,
wait,
sir.
sir, shall I? Dr. Devan is here now.
Yeah, he can answer.
Dr. Devan, can
Yes.
you come in? Now the Dr.
Vaidyanathan.
Dr.
Yes, sir.
Vaidyanathan has a query that
Yes.
we have a couple of good cardiologists and cardiac anesthesiologists who are regularly attending our courses, and we couldn't go, we couldn't have TOT done for them. So this is where the problem is. And he says that we need to have more instructors for the start of CRTC center. So how can he be helped?
Am I audible?
Yes, sir.
Okay. Can you repeat the question because I was not able to listen properly?
Dr. Shiva, can you please, Dr. Shiva, can you please mute your mic?
Shiva's phone, please mute. Dr. Shiva's.
Dr. Shiva, can you please mute yourself?
Somebody admin can also do it. Arun, can you mute him? You can do it. Yes. So can you repeat the question?
Probably harder.
Vaidyanathan?
Go ahead, sir.
Sir, good evening.
Good
As usual, very nice presentation, sir. Like what my query was, I got around 4 instructors now, which you have been doing. When it comes to doing CCLS, I find 1 or 2 instructors short occasionally, sir. So I've not been able to, I think sir left again.
No, I'm here listening.
Yeah.
Okay, yes, sir. So most of the time I had to rely on Chandrika ma'am. So I have to trouble Chandrika ma'am repeatedly. You send at least 1 instructor. We are falling 1 instructor short because especially the batch is around 30 to 40 postgraduates. We have got a couple of cardiologists and cardiac anesthetists who are regularly attending our courses and who are really passionate about teaching, and they are very well ours with our guidelines, Indian Resuscitation Council Federation guidelines, and they know everything, sir. The thing is they couldn't do TOT earlier. So I just want to add to our instructor potential.
We cannot be, because we are making a very robust system of making the faculties, but it's very easy. There are so many TOTs coming up. Like I recently did in Chennai. Again, I am doing in Chennai next week, week after this. So some kind of TOT where we do a micro teaching, and we have to follow those norms. And will be, on the contrary, they will be an asset to you. If they are cardiologists or they are physicians or emergency medicine specialists who have been teaching, but to get into the defined fixed course where we have a very structured course, I have seen they talk little extra sometimes, and they divert also sometimes. They teach this also, do this, that also. For that, I think we need a TOT properly, and we can think about them how to quickly and smoothly enroll them as a faculty. Just let me know, because the first time you raised this point to those who have been, and they've done a provider course anyway.
Yes, sir, they have done. Yeah.
We make some provision for them. Based at Mysore, no? You are at Mysore.
Yes, sir. Yes, sir. That's right.
Yeah. So I know Dr. Chandrika is very kind enough to travel every time, but she also is a very busy person. And nowadays the number of courses are increasing so much that we'll have to make a very robust and successful system. So we'll think about what to do about your 2 people. I'll discuss with the core group, everyone, and then we'll get back to you soon.
Dr. Kesh Garg is there with his hand up. So Dr. Garg, please go ahead.
Sir, thank you.
I had a question.
Dr. Chandrika, we'll take up that question later. Please hang on.
Okay.
Dr. Garg, please.
Okay.
So my suggestion would be here that whenever you conduct any of the provider courses, try to identify the good instructors. So each provider course, especially those who are faculty and all aspects, try to identify, which Dr. Devan mentioned in one of his slides, the instructor potentials. they will be good. Out of 32 people, there will be at least 1 or 2 persons who are good. Make a record of it. If they are performing very well in the skill stations, they have scored 90% marks in the post test. They are good in verbalizing. They are good in communication. They can be groomed up. And then subsequently, once you have around say 10 to 15 people in say next 4 or 5 courses, you can we can arrange a TOT at your place itself, so that you have more pool of instructors for future courses. Because even when you are doing every weekly, say 4 people may not be relieved from the department every time for 2 days. So that's why if you have say like say AIMS right now we have 10 people. So out of 10 people, at least 5 will be free. Similarly, like Southern hospitals, they have 10 people, so 5 will be free. So in this, you can increase your pools and you can share with each other so that you becomes independent and self-sufficient from each center. So try to increase those pools and try to identify instructor candidates from each provider courses. Thank you, sir.
Dr. Vaidyanathan, you can write to Dr. Diwan
Yes, sir.
on the website nhq@cparindia.in. So I'm sure he will guide you through the process. Dr. Chandrika wanted to say something. Dr. Chandrika, please.
It's in continuation with Dr. Vaidyanathan's question. See, the
Please.
problem I'm having in Bangalore is lot of them have done their TOT and the courses 2 years ago, or the instructor certification. So now the question they are having is, my instructor certificate is 2-year-old. Can I still go and instruct? So we need clarity on that. So do I just get them to do another TOT, or how does it work, sir?
See, probably if they have not taught enough courses, which I mentioned in the lecture, they have to undergo the TOT. And it was very unfortunate that last 3 years, we were handicapped a little bit because of COVID time and all. We had to do a lot of online TOTs to create the awareness. So that was the main aim. And we are trying to sensitize the people for the Indian guidelines. But now we are through with that difficulties. And so now we have to have a very robust system. And we must have and there's a one-day TOT program. There is nothing harm, because there is always a lot of things to learn if you have not done any courses before. In fact, if you have not taught any courses in 2 years, they have to do the provider course first. I would recommend that, and then a TOT, and then follow and they will be very good teachers. But there has to be a reason why they became a faculty before 2 years and they did not do any courses. Either there is no record, or they were ignorant about this, or they did not get the opportunity. It is all same, because if I have not taught for 2 years, I think I need to learn a lot again, because all teaching skills we start losing, particularly in the resuscitation guidelines. So that is what I strongly recommend.
No, sir, these people have been regularly doing courses. It's not that they have not been doing courses.
No, if they are doing the courses, then certification renewal is automatic. If they have been teaching,
so
and
we
they
just, yeah. So we just write to you and you will recertify.
So that is, you write to admin and me both, and it is done online only. But we have to write how many courses they have done.
Yeah, that we'll do. That we'll do. That's fine.
That is the role of a CRTC coordinator. He has to maintain the list of the data or the logbook of this faculties he has involved in various courses. This is very easy. If they are taught, we are very easy. We can renew them easily. And we have been doing it also. It's first time you are asking on the webinar, but many places they have already, particularly BCLS courses are going on a lot. In the state of Andhra Pradesh, so many, they are doing 5-7 courses a year. We have already renewed their BCLS certification.
So there's Dr. Somashekar who has his hand up. Dr. Somashekar, please go ahead.
Thank you, sir. Very interesting and good presentations. I have a question, because I spoke to Dr. Patel few days back, and this was related to we're going to have a CRTC at our medical college. And for the creation of instructors, there was some discussion. So I have a question related to what kind of faculty, like I know anesthetists, internal medicine people can become faculty members if they do all the processes as mentioned. But can other faculty members, like say pediatrics, physiology, or anyone who's interested in teaching and is otherwise a faculty member, what is the is the process the same, or what is expected? Because the reason I'm asking is because in physiology, many people teach resuscitation to first MBBS students as part of the curriculum. And so they also might currently. And so if they are doing it by reading and teaching, can they become instructors?
Dr. Diwan, sir.
I just mean,
There is there's one iPhone which is not muted, and there's a lot of disturbance coming from there. I request the person to please mute his mic.
yeah, I could understand his question. See, first of all, they have to undergo irrespective. There's some.
Dr. Rashesh, your two phones are on, so they are echoing the voice.
Actually, he is not taking chances because of the rain. He is having problem with his connections. So he thought maybe two of them should be kept working in case one is not working, the other one is always well.
Separate rooms, separate rooms.
Yeah, maybe.
If he goes to separate rooms, it will work fine.
Go ahead, sir. Sir, we can't hear you.
Regarding taking somebody as an instructor, you can take from physiology or any other branch who can teach, even the nurses. Actually, in fact, in AHA, even the ambulance drivers are coming here as instructors. So it is not the, actually, it need not be a doctor even a physiotherapist or emergency medical physician technicians who can deliver their goods can be taken as an instructor. But the problem here in India is if they are somebody, if they are not doctors, people may not give that importance unless they are different skinned.
And that's a problem.
So,
the question is, the CRTC coordinator has to approve the instructors. So the process remains the same whether they are technician or anything. They pass through the provider course, they pass through the TOT. If they qualify that, that means they are good enough. But the aptitude, their passion, and their delivering of the stuff, you have to assess. Now, with the passion, you make them faculty. But like one of the medical college in Nagpur, I recently talked about that there are pediatricians, but there are orthopedic surgeon, ENT surgeon, radiologist also. So they distributed that, let them, because in a course, we need more BCLS faculties. So they are more in the BCLS, and intensivist, critical care people, physician, anesthetists are more in the CCLS. Like that, they're distributed, and that's a very fair distribution in my opinion. So we justify
Guwahati, there are different people like critical care and orthopedic surgeons.
Yes, sir. And many places across the world, I have seen there are no anesthetists, not emergency people. They are too busy consultants. They are the paramedics who have been doing these programs, and they are equally very good. Unfortunately, our consultants who are physicians or something, I have seen they talk a lot of extra things during the course, which is not necessary. So that restricts when there is a paramedic working, he talks little focused only. And that's place where our aim is when the students come for the course, they should have all theoretical knowledge and they've done it before. They've already acquired that knowledge and they've done a pre-test before. So when they come for the course, it's a skill training. And skill training, I think the paramedics do very well. So we have to see that what role you assign to which faculty in your, but there is no harm in making such people the faculties. Anything?
There is one hand up of OnePlus. I request the members to please put their names rather than the brand of their phones. So OnePlus, can you ask your question, please?
OnePlus, okay,
Yes.
He is there.
Please go ahead with your question.
She.
Can you identify yourself? OnePlus? You unmute yourself first.
Yeah, unmute, madam, unmute.
I request
settle down at one place and do it.
Yes, we can. Please go ahead.
Sir, I am Dr. Ranade. I am practicing in Konkan, that is the west coast of Maharashtra. And I am an instructor, but like Chandrika madam also said, I did my TOT nearly 4 to 5 years back. I need to start a CRTC in my hospital. However, one second, sir. Because of the stringent guidelines of starting a CRTC, my hospital is not able to fulfill all of them regarding the area or whatsoever. Now, I work, ours is a trauma hospital and it is in a taluka place. But from Mumbai to Sindhudurga, the West Coast, there is not a single CRTC. And I do quite a lot of work on coals and BCLS. So my request is, can the guidelines be a bit softer on a smaller town place or a place where I'm not able to fulfill all of them? Is it possible?
Dr. Devan, sir.
No, I don't think, I'm afraid we cannot entertain that because you see, a simple example I'll give you. We are teaching 3 guidelines, course,
Yes.
BCLS and CCLS.
Yes,
In
sir.
all 3, one is designed for common citizens, right?
Yes, sir.
The people. Do we compromise in compression? We teach the same compression which we teach to the intensivist in ICU, right? So in resuscitation, which is the most important point, there is no compromise. So we cannot be liberal even for the CRTC like that in a subject of resuscitation. And my aim is, in your a small place, why you want to create a CRTC? You need to do only provider course to all of you, and you be the instructor somewhere else so that you can travel and join any CRTC. So your aim of becoming a faculty is certified. Is you are happy with that? But in a smaller place, I think I would not justify to have a. And how much liberal you want to be? What do they expect? Your hospital.
No, see, ours, sir, ours is a natural calamity prone area. It is flood prone, and we have
That
landslides.
means you don't need CRTC. You need every of your staff member to be trained for the provider course.
So they are
Not
trained
only-
already. But the
No, no,
people
not
of the
only
town, they
anesthesia,
request me कि
also
madam तुम्ही
trauma.
certificate पण द्या आम्हाला. So that is why I wanted to ask you कि only
I think
course
we
is also
cannot
sufficient.
compromise with the CRTC. Anybody wants to add? Dr. Chakra sir, Dr. Rakesh, Saint Moin?
I did talk to Dr. Chakrarao and Dr. Rakesh sir few months back. I did want to start, and I'll
I'm
try
sure
to my
they
best to
will.
fulfill the guidelines.
Yeah, I think
Look,
Madam
yeah,
point
go ahead.
is well taken, but we also need to understand that for IRCF CRTC guidelines, it is already very liberal. We are already on the brink. So there is nothing
Yeah.
less than that. We are not
Yeah.
putting so
It's
many.
already liberal.
We are not saying that you should have a faculty lounge, you should have a good dining area with sitting capacity. We are not forcing on those things. So that's why there is no scope of undermining it further. You tell me, madam, you need a people of 32 hall with audio visual to sit for the hall. You need it or not? You cannot.
Around, might be the batches might be say 20 to 25.
Right. So you need a hall where 30 people can sit. This is what IRCF wants.
Yeah.
We want all the mannequins. That is what IRCF wants.
I have the mannequin, sir.
We just want 4 different spaces for the skill station. That is what we want. So out of these mannequins, skill station rooms, and teaching with audio visual aids. I think this is what Ashish Divajan mentioned. So I think there is nothing stringent about it. And there should be 5 faculties definitely which are IRCF trained, has to be there. And obviously, as a courtesy, you will let them eat some food in lunch and tea in morning and evening. So I don't think there is anything which can be deleted from this.
So we are short of faculty also.
No, so that has to be followed. That has to be.
More liberal. We recommend 6 faculties.
Oh no, but anyway, I'll try now to gather as many people. But like I told you, it's a bit difficult.
We'll send somebody to inspect you and give a position. I don't know whether we have kept very basic minimum.
Yes, yes, sir. And I have also talked to you about it a couple of times, and you have been very kind to me about that. So I invite all of you. I'll try my best to follow the guidelines, and you please come and visit our. Sorry, sir.
Which place you are?
Sir, we are on the Mumbai-Goa highway at the foothills of Fort Raigad.
Okay.
Right.
Yeah. So Mahad is a taluka place and it is a
Okay,
known
we'll go,
prone
we'll
flood
go to
area.
Goa and stop at your place.
There's a
Definitely,
place
sir.
they get a lot of trauma.
बहुत
Trauma.
ज्यादा.
Yes, I know that.
Yes, sir.
Any other
Definitely,
question?
I'll try my best to fulfill the guidelines, but I might
Good.
fall a bit short.
You see,
So
everybody must understand the intention of IRCF to have this being developed in the last 6 years is to train our own citizens to the best,
yes,
to the international guidelines or better than the international guidelines.
yes,
So
sir.
we are promoting many CRTCs, but we cannot compromise in the quality of the work we do just because we are good, but we don't have enough infrastructure. So like
Actually,
that, if AED is not there, I don't allow basic caterpillar life support course. AED trainer has to be there. Like
बिल्कुल.
that, for LED generators, EDA module, the task utility spacing, everything has to be there. Then the infrastructure is complete. And let me tell you, we are observed by international people, so we cannot compromise in the quality of the training we give. And that's
Okay.
why we are going to be very stringent even for the faculties now. And although we want to make so many faculties and so many workload is there for so many centers coming up now in the medical colleges, but we have to work hard for at least 1 or 2 years to create that standard. We have to raise the bar. We cannot compromise.
Right.
Okay, sir. Thank you.
Right. Any other
But
question?
Ravindra Bhaskar, Bhaskar, will you say something?
Dr. Bhaskar, please.
Bhaskar, Vena Chatra. Bhaskar from anybody wants to tell anything?
I think the participation has gone down to only 30 now.
40.
I think
40
yeah,
including
41.
all of us. 40
There
include
are 80.
our team.
Rajesh Kumar, will you tell anything? Umesh Badane is an important person for us.
Shivani, I think has left.
No,
I think
Umesh Badane.
he had left.
Anybody? Kushal Babu?
Is Dr. Lokesh Idara there?
Lokesh Adara is there.
No, but
Lokesh?
he's not coming online.
Sir, can I say something, sir?
Please go ahead,
Yes,
Dr.
Rajesh. Yes,
Go ahead.
please.
You
Sir,
introduce your name?
good evening. Sir, good evening, everyone. Sir, I'm Dr. Rajesh from Tirupati. So my what I understood is it would be better if we introduce basic life support right from at least from 6th class, sir, so that if school children and every college students are trained and then there will be most effective we will be more effective in and successful in resuscitation and we will be we have to train our teachers also and our lecturers also and apart from calls which we are training this we have to concentrate more on our training our students and lecturers teachers also, sir, so that it will be very helpful and so the I want the expert group to comment on this.
Thank you, Dr. Rajesh. Dr. Diwan, would you say?
Actually, in 2019 itself, Dr. Rakesh has approached the director of CBSE and got it is included in the 9th class curriculum because up to that age of 14, they may not be able to effectively compress. Of course, in European Resuscitation Council, they have advertised that kids can save the life and all those things, but it is not that easy to compress a test for everybody. But the issue is the kids will be available in the house, and about 70% of the cardiac arrests are occurring at home. So I think the children has to be trained. But because of the COVID after 2019, they have not taken any interest. And unless it is forced as a part of the examination or part of something, even if it is kept in the curriculum of the CBSE in 2019 itself, it has not come to the practical aspects. Now we are now coming out, but because we do not have that much of men also. In every medical college in Andhra Pradesh, every medical college and nursing college, we have started a CRTC. Even then, for them, they are very busy in the operating theaters, other places, and all. These people like school children and all, it is very difficult for them to convince, even though they pay lakhs of rupees for the school fees, to pay even for 500 rupees for to train, it is becoming difficult. We need some sponsors or the CSR funds to train, because even I tried many times in my college guest house. The thing is, we have to pay for the electricity, we have to pay for the boys and attendants, and we have to give them some tea and snacks to the school children. So it is a bit of cost, and the printing and giving them the certificate is also expensive. All of them, it costs not less than 150 rupees or 200 rupees in a small setup in a small village town like me. So these things are there, but now we have come to a thinking that we have to train the physical education teacher where and give them one mannequin. Who will give the mannequin? IRCF cannot give the mannequin. There should be a person, there should be a sponsor to give the mannequin, and the PET teacher or any other body, they have to teach the CPR in their PET classes along with their drill period. So this is one thing we wanted to suggest to the government of Andhra Pradesh. And other thing is the nursing. So the government of Andhra Pradesh, all the nurses who are already in the service were trained by us. And not only that, now we are training we made it compulsory to train all the nursing students, and it has come into their curriculum actually. The Trained Nurses Association of India is insisting, and they have kept it in the curriculum of the graduate nurses and diploma nurses in the last year, in the final year, to have even the CCLS. So it is important for them. Now we are also making up, and even for us, with a lot of efforts, we are taking preventive medicine people also as instructors. We are taking physiology people also as instructors. We are taking some of the nurses. Nurses are teaching well also. They are MSc and PhD qualified. So like that to happen. But even then, a few days back, the electricians working as linemen and all, they have asked us to train them. But then I have sent them to the medical college. They are obliged to train them. So all these things, sometimes our anesthetists are foregoing their practice and conducting these classes. So at least, actually, my people in Andhra Pradesh, they have declared at least we need at least 5,000 rupees per day for teaching these people. So this is not a big amount, actually, when compared to what they are charging for the other resuscitation councils. We are just charging about, even for 1,200, 1,300, we are training the people. And in places like Mangalore, they are training even for 700 rupees, giving 550 rupees to IRCF for the book. So this is all how we manage. So we are now, for a BCLS, we are asking them to come after lunch, and teaching them from 1 to 6 o'clock and sending them with tea and snacks. So this is all to cut down the expenditure. So actually the expenditure is not much, but when we are coming out, they are thinking. One doctor said they are thinking that we are getting a lot of money from abroad or from the government of India, and it is nothing like that. We are struggling a lot. We have our own passion to teach people, and we are conducting the programs like that. This is what. And can anybody will talk like Sur Setti or any other person? Chandrika,
Dr.
Janathan
Surisati.
knows all the
Sir,
difficulties.
good evening. Sir, good evening, sir.
Good evening.
Good evening, sir. Rashid sir, Chakrao sir, and Rakesh sir. And one more session regarding Rajesh doubt. Sir, we can write this education people, the education minister, so that all the 10th class students, they must train in CPR. We can like that. We did all the nursing students now with the effort of Dr. Chakkar Rao. Now we did more than 30,000 MLH pills, multi-level health providers we trained, and now we are giving training to the nursing students also. There are around 30,000 in the entire AP state. The program is going on, so that we can write to the education minister or authorities, so that at least the student of at least 10th class, he may know about the little bit of CPR, then they will come to us. We can write a letter from the ARCF, so that regarding the awareness of CPR, so that surely they will come to us. Then giving training to the teachers regarding the calls is not a big deal for us. We can do, because we are doing daily training. And one more thing, sir, regarding electrical employees training. SV Medical College Tirupati is a recognized first aid training center in the AP state. We are giving calls along with all other first aid training for all the electrical employees. So if any electrical employees ask you, sir, please ask them to contact their authorities. They will forward them to us. We are teaching the calls for the all electrical employees also. Oh, so it's not a big deal for doing calls, or any other institution. They will ask for the calls in especially in Andhra Pradesh. So more than 41 CRTC centers are there, sir. All centers they will do without charging anything. Our CRTC coordinators, they will go they will teach the calls, especially for calls. For BCLS, everything they have to purchase the books. So it's a cost, it will become some cost. But for calls, we are doing like a corporate social responsibility. We are teaching the police people, we are teaching the RTC drivers, and we are teaching the students also. 10th class students also we are teaching. We are teaching police training schools. We are going there. We are teaching the calls. So all our CRTs in AP, we are doing the same thing, sir. But one setback is that they are not recording that work, whatever they are doing. So I'm insisting that all the CRTs, they have to record. They have to record, so that our work should be it will be recorded. Whatever the work we are doing, we have to show through the IRCM. So that is my request for all the CRTC coordinators. I know daily I am seeing they are posting, we are conducting CRTC from there like that. So please post in a Facebook, IRCF Facebook page is there. Please post in that, and we can record it. Today we conducted around 50 calls training programs. And recording is very important, sir. The work of IRCF, that you have to do things. This is my suggestion, sir. Thank you, sir.
Thank you, Dr. Surisati.
He is already
Any other?
The University Grant Commission has sent a message circular to all the educational institutes to conduct the CPR programs. This has come about a week back, and 2 days back, one doctor, I'm forgetting, actually he's a friend of Dr. Rakesh. He has told me, see, we have to improve, we'll do that thing, this thing. And then I said, I forgot his name, I'm trying to recollect. I have become old. So at the time when we are inaugurating our Journal of Resuscitation, we will also invite him. We will conduct, we will talk to him. He is a very good friend to him. And of course, he knows all the, by virtue of his staying in All India Institute, he is the boss for us. And he told me that we will mobilize many more things, and we can do that. So definitely the University Grant Commission has already sent. It is all, a lot of things are happening for us. But the thing is, not only the thing, we want more instructors, more people to join us. We should have an army of people to work. So that is the most important.
Okay. Any other?
Rakesh, do you remember the person? I don't know.
Which one, sir?
There is one person yesterday, he called me. I sent him some message. So he called me and he is our friend. He knows you well. So and that is the thing.
Okay.
And regarding the journal, I talked today. Of course, he always he is missing. Today, he said that it is not possible to print it in this issue. But today he has immediately said at 2 o'clock it can be printed. So we want some advertisements. Immediately I told of somebody. Almost 3-4 people have accepted to give one full page advertisement. I told them it is minimum 2 lakhs per year. So it will be, probably it may be done already. Some feedback from Mindray, it can be done. So that is not a big issue. I'll find out this name and let you know. Anything, sir? Anything anybody wants to talk?
Is Dr. Lokesh Sharara there?
Lokesh? Lokesh must be there.
I
He is there.
No, he is not on in front of the computer. He is there online, but
He is available. He is online, but he's not there in the sitting on the computer.
I think we end the session now.
Yeah, already 9 o'clock.
Do 9 o'clock.
Yeah.
3 hours is a good length. Okay, thank you very much. Thank you all. If there is anything, please write me a mail with NHQ director and admin three mails so that one of us will be answering. Thank you, Vaidyanathan. Thank you, Chatna.
Thank you, sir. Good night, all.
Thank you.
Thank you.
Good night, everyone.
Thank
Thanks for participation, active participation.
Thank you. Thank you.
Good night.
Good night.
Good night.
Thank you, Pandanayak. We'll meet. Thank you, Mukul Kapoorji.
Good night, everyone.
Good night.
Thank you.
Bye. Good night.
Oh,
Thank you. Thank you.
Thank you.
bye.
Bye.
Madam Chandrika, I think you have to go to this Whitefield.
Kollichallam. I'll talk to him. Yes, sir.
I will also come.
Okay, sir. When are you coming to Bangalore, sir?
I don't know. I have a lot of program in Chennai.
Okay, I will talk to him. I'll do the preliminary work, then we'll decide when you.
Yes. You fix the date. If it is possible, I'll come.
Okay, okay. Yeah.
It is just direct flight for me.
Yeah. You can come in the morning and fly out in the evening. So no problem.
Or even train is night. If I can sleep here, morning I can get down.
Okay. I think you should fly, sir. Why should you take the trouble?
That's fine. Thank you.
Yeah. Okay.
Thank you. Thank you, Chakrara sir. Thank you.
Madam,
Thank you, sir.
we
Thank you, all of
have
you.
to take a date from Dr. Manjunathan. We have to meet him.
Yeah, I think we should try and do both together.
Yes.
The CRTC, and we'll try and take a date, sir.
He is the person who has helped us a lot.
Yeah.
And he has become an MP now.
Yeah, we should catch him. I tried contacting Dr. Sridhar Shastri, but I've not got a reply. So I have to find some other way to contact him. Let's see.
I'm writing him many mails, so he's not replying.
That's what. So we have to see some other way to contact him. Let's see.
Shankar, will you like to talk something? Shankar is not there.
No.
Alok must be down. Alok has become a big man now.
Okay, sir. Thank you. Good night.
Okay, ma'am.
Bye.
Okay.
Bye, Chetna. Bye.
Thank you.
Thank you, sir.
Bye,
Bye,
Chatna.
ma'am.
Good night, sir.
Bye. Good night, sir. Good night, everyone.
Yeah,
Good night, Chatna.
Thank you,
Pandanayak
everyone.
garu
Thank you, sir.
వస్తాను హైదరాబాద్.
Okay, sir. Rand, sir. You are very much invited, sir.
No, I have some good retired IAS friends. I have to meet them and we have to teach
Rand, sir.
them.
మీరు వచ్చినప్పుడు చెప్పండి, sir. Rand, sir.
Okay. Okay.
Okay, thank you.
Okay, Rakesh,
Thank you.
thank you. Alok,
Yes,
will you
sir.
say us anything?
Sir?
Will you say anything?
No, sir. No, sir.
No, no. Okay. Thank you.
Yes, sir. Yes, sir. Thank you, sir.
Take care of us when we come to Tirupati.
Yes, sir. Yes, sir.